Good evening, everybody. I'm Dr. Rishi Swaroop. I'm the Secretary of Hyderabad Ophthalmologists Association, and I take pleasure in welcoming you all for this wonderful Retina meeting today. After a very long gap, HOA has organized a webinar, and Dr. Malika Goyal has put together a wonderful program with experts in Retina from all over the world, our star attraction being Dr. Huang from Cleveland, and I'm sure all the other speakers will do a wonderful job. I wish you all a wonderful evening of academics and all the best for this wonderful webinar. All over to you, Dr. Malika.
Thank you very much, Rishi, for all your support. Thanks a lot. So, this is our meeting and the program. The first three talks are the surgical talks by Dr. Mudit Tyagi and Dr. Shanmugam, followed by an enigmatic retina scuffle by Dr. Lalit Verma. Dr. Subair Huang will speak on complications of anti-VEGF therapy. Dr. Jay Chablani on new multimodal CSR classification, followed by threat to life in vulnerable patients by Dr. Subhadra Jalali. So I'll just briefly introduce the speakers. Dr. Lalit Verma, we are extremely grateful to him for joining us. And he's the Director of Retina Service at Center for Sight and currently the Vice President of AIOS. He has been the Chairman Scientific Committee of AIOS for the last 2 terms. And in that time, he has made the scientific program extensive, intensive, very practical, and very inclusive. He has issued many AIOS guidelines on the management of common problems like endophthalmitis and DME. He has been the Joint Secretary of AIOS. He has also changed and transformed the Delhi Ophthalmic Society and has been its president, as also the Vitreoretina Society of India. He was the additional professor at AIIMS for 14 years, during which he has been teaching several postgraduates and has done extensive community work. He has 172 publications, has overseen 38 theses and projects, several chapters in books, and several awards and orations to his credit. And he will be introducing Dr. Huang later in the session. We'd also like to thank Dr. Mahesh Shanmugam, our guest faculty, who's the head of VR and ocular oncology services in Shankar hospitals in India. He has over 2,800 citations, 175 publications, several chapters in textbooks, has been training vitreoretinal fellows, and has several awards to his credit. Dr. Subhadra Jalali from the HOA, she's the Director of Retina Institute and the Newborn Eye Health Alliance at LV Prasad Eye Institute. I think there's some problem with my... She's had fellowship training at the best places in the US in ocular genetic diseases and electrophysiology, as well as in the management of ROP and pediatric retinal disorders. She has several publications and book chapters to her credit and is on the National Task Force on ROP, the Government of India. She has several awards to her credit. Another guest faculty, international guest faculty, Dr. Jay Chablani, specialist at the University of Pittsburgh in USA. And he's published several articles with a focus in the field of choroid. He's the editor of the books on choroidal disorders, central serous chorioretinopathy, choroidal neovascularization. He's on the editorial board of several journals, including the American Journal of Ophthalmology. And he has several national and international awards to his credit. So welcome, Dr. Jay Chablani. We are really thankful to you for joining us. And Dr. Mudit Tyagi, he's a consultant in retina and uveitis at LV Prasad Eye Institute, with areas of interest being ocular inflammation and complex vitreoretinal surgeries. He has achieved several awards, including the Honor Award from the ASRS, Award for Best Surgical Videos in URetina and ASRS, and the Vitreoretina Society of India Award for Best Innovation in the year 2019 for his work on fibrin glue in retinal detachments, which he will be presenting in this meeting. Thank you very much. Dr. Mudit Tyagi, please.
All right, thank you, Dr. Malika Goyal ma'am, for such a kind introduction. And Are my slides visible? Can I start?
Yes, please.
Yeah, so first of all, I would like to thank Hyderabad Ophthalmic Association for giving me a chance to present our work on this novel surgical technique, which we have been working upon in the last 2 years, which utilizes the use of fibrin glue for rhegmatogenous retinal detachments. I don't have any financial disclosures. Now, if you look at it conventionally, the treatment for reg RD has been either a scleral buckling or a pars plana vitrectomy or pneumatic retinopexy. However, over the last few years, there has been a definite trend which has been tilting towards vitrectomies for treating these diseases. In fact, even the ASRS Specters and Trends survey showed a preponderance of preference for a vitrectomy for superior as well as for inferior RDs. Now, when we talk of vitrectomies, the main way through which we address a reg RD is we do a complete pars plana vitrectomy, then a subsequent closure of break by either using air or PFCL, a laser or a cryopexy around the break, and then subsequently a tamponade, which can be either oil or gas. However, there are problems with conventional silicone oil and gas tamponades. Post-operative positioning is needed for most of these cases. There is a problem of incidence of glaucoma or corneal changes and cataract. Redetachments are known to occur after oil removal, post-operative hypotony, repeat surgeries, restriction in air travel if you have used gas, and more importantly, a delayed visual recovery till either the gas bubble gets resolved or till you remove the silicone oil. So keeping this in mind, we were thinking, is there something which we can do to take care of the problems which are caused by tamponade, and how can we obviate these problems? Now, if we look at it, what does tamponade mean? The word tamponade comes from the word tampon, which means to plug. And in RD surgeries, tamponade agents are usually used to provide surface tension across breaks to prevent a further fluid flow into a subretinal space till the time the effect of a retinopexy becomes permanent. And this effect of retinopexy has been shown to occur within 18 hours after laser photocoagulation, and the maximum strength is usually reached on day 5. So essentially, we need an agent which can provide tamponade agent strength till the time the effect of laser becomes permanent. Now, coming to that, then we thought that can we use fibrin glue? And fibrin glue basically is a mixture of aprotinin, fibronectin, and plasminogen. Has already been used extensively in ophthalmology, in ocular surface procedures, in scleral fixation of intraocular lenses, and even in retina in optic disc with associated macular detachments. There have already been studies on its safety profile also earlier, where not only animal models have been there, which have shown that it is non-toxic to the retina. And it has, like I said, already been used earlier in optic disc with associated macular detachments and even in full thickness macular holes. And therefore, we decided to use fibrin glue as a tamponade agent. And this is the basis of the surgical technique. What we do is that this is an RD with an inferior break. We do a complete vitrectomy like what we would do in any of our cases. Subsequently, do a fluid air exchange, settle the retina. After that, do a laser around the break, which anyways we would have done. And after that, in an air-filled globe, instead of putting oil or gas, you just put a drop of fibrin glue, which covers the break. And essentially, you've got a plug which is tamponading or closing the break. And that is all which you need to do. And you don't have to give any post-operative positioning to any of your patients. So this is a surgical video again of the same technique. This was the patient with an inferior RD. Where you can see that we are now doing a complete vitrectomy. And subsequent to the vitrectomy,
the break was marked by diathermy.
The break is marked with a diathermy.
And subsequently, a fluid air exchange was done. The retina was settled and endolaser was done around the break.
So after settling the retina over here, you do a laser like what you anyways would be doing. And after doing a laser, now this is an air-filled globe right now where you have done a laser, and then you just inject one
After
drop
this,
of...
in an air-filled globe, fibrin glue was injected over the break. Care was taken to inject the thicker component of fibrin glue initially, followed by the thinner one.
So the idea to use a thicker component first and then thin is to prevent a subretinal migration.
A fibrin glue coagulum is formed in 5 minutes.
And then you can
Fluid needle was used to reposition the coagulum over the break so as to cover it completely.
So what you can just use is either you can use a fluid or even a forceps and just roll this coagulum back. The idea is to cover the break with this coagulum of fibrin.
The idea is to use the fibrin glue plug to cover the break and prevent further fluid flow into the subretinal space till the effect of the laser retinopexy becomes permanent. At the end of the surgery, balanced salt solution was switched on and air was removed.
So subsequently, we just removed the air and we left the eye under fluid. And this is the first post-operative day picture of the patient, where you can see an attached retina and you can see this fibrin plug which is covering the break. So this is how this patient's case evolved. You had an RD, first post-operative day, and then at 2 weeks, the entire fibrin glue just gets resolved by itself. It gets absorbed and you've got an attached retina with surrounding laser marks. So this was how this patient's progress evolved. Now, when it comes to injecting the glue, one of the easier ways which we have found is that you can use this microdose injection kit, which was brought by Micromed to basically inject subretinal TPA. But you can use the same injector connected to your VFC, and with a foot switch control, you can, in a very controlled way, deposit just 0.1 ml of the thick as well as the thin component of the glue using this. So let me just show you one more video which shows how you can just deposit the glue. So this is, you put the thick one and then the thin component both over the break. This is a lasered break. And after waiting for 3 to 4 minutes, you find a coagulum is formed. And then all you need to do is just lift this coagulum simply with either a forceps or a flute. Here I'm using a forceps, and just deposit this coagulum over the break. So what you have done is you have covered the break with your fibrin coagulum. And that's all you need to do. You can either, if you want, leave the patient with the behind with just an air bubble, or you can even remove it. We have actually, in most of our cases, gone ahead and removed the air bubble also. So that's all you need to do. And this coagulum goes away, gets resolved by itself in the span of 2 weeks. So this is the surgical technique. This is just one more patient which had an RD and a break superiorly. And this is the first post-operative day picture, where you can see a small air bubble over here and a fibrin plug covering the break. And at 2 weeks and 1 month, again, we can see that the entire glue has got resolved and you have got an attached retina. One more of our patient with an inferior RD and 2 temporal breaks. And this is at 1 month, 3 months and 6 months. Another one patient with an inferior RD, where you can see this plug over here. Now there can occasionally be a problem of a subretinal migration of the fibrin glue sometimes, but that is not to be worried about, because this subretinal migration also gets resolved by itself. So this was a patient who had a subretinal migration of glue, which you can see, but at 1 week, again, most of this has gone away. And at 2 weeks, this entire subretinal tissue has gone and you have got an attached retina with the surrounding laser marks. So we have till now done around 31 cases, and the only complication which we found was that 3 eyes had an increased post-operative inflammation on the first day, but not significant, something which we could just easily manage by just giving 2 hourly steroids for 1 week. None of the eyes had an elevation of IOP. 5 eyes had a small subretinal migration, but which resolved by itself at the end of 2 weeks. 2 of our cases also had a cystoid macular edema, but then these were pseudophakic cases with a complicated cataract surgery which had been done earlier. So now whether we can attribute it to the surgery or not, difficult to comment. But the point is that after using just topical nepafenac eye drops, the pseudophakic macular, the cystoid macular edema also got totally resolved. So to conclude, fibrin glue tends to get resolved by itself at the end of 2 weeks, a time which we believe is sufficient until the time the adhesive forces of laser photocoagulation set in. Most importantly, no postoperative positioning is needed for any of these patients, and we can get away without silicone oil or gas tamponade. Thus, we can prevent most of the complications which we face with these. However, the point over here is that it cannot be used. Some of the exclusion criteria, we cannot use it for breaks, larger breaks, because if it's a break which is larger than 2 to 3 disc diameters, then you will have a larger subretinal migration. So for simple uncomplicated RDs with 2 or 3 breaks within 1 or 2 clock hours, and where the break size are small, we can safely go ahead and use this technique. It's a promising technique for simple uncomplicated RDs, allows for a very early visual recovery, no postoperative positioning, and avoids all the usual problems which we face with silicone oil or gas tamponades. So I would just like to acknowledge some of my friends and colleagues, Dr. Sangwan and Sayan, and Dr. J, Dr. RN, Dr. Rajiv, Dr. SJ, Dr. Das, all of my colleagues in the department who a sounding board, and I used to discuss this problem while I was working upon this, and you were kind enough to give me their feedbacks. So thank you once again. And with that, I'll stop my presentation.
Excellent talk. Questions from the panel?
What about PVR patients, Mudit?
Sir, PVR patients, it will not work. We did into 1 or 2 cases, but patients with an extensive PVR, I would not suggest using fibrin glue. One more caveat, this is not a technique which is a replacement for scleral buckle. So if you have got a very peripheral break, I would still prefer to go for a buckling, not for a vitrectomy. But for relatively posterior breaks, 1 or 2 breaks, this is a very good technique. Even for inferior RDs, we have now had around 19 to 20 patients who had an inferior RD and it works very well.
Any difference between superior and inferior RDs on success rate or this thing?
Nothing. In fact, superior sometimes can be a little bit more trickier because of the fact that sometimes that glue can trickle in a bit down. But inferior RDs, in fact, are much more easier to manage with this.
And the last comment, if I saw your video correctly, was that the thicker and thinner component, you put it on the posterior pole and then pick it up with force and place it there. Or both the glues are done on the break.
So both are done on the break. You put the thicker component first and then a thinner component. But even in spite of it being under an air-filled globe, even when you put it, it will still trickle down and spread around a little bit. It forms a kind of a spreaded coagulum. So at the end of the surgery, after 3 minutes, when that spread coagulum is formed, you can just take it and deposit it back over the break. But you have to put it over the break.
Mudit,
Yes.
if there is a vitreous, residual vitreous over the surface of the retina,
Yeah.
before putting the glue, what will happen?
So ideally, there should not be a residual vitreous over the surface of retina, sir. So we ensure that a complete vitrectomy has been done and there is no vitreous covering the break. And you try to do as complete a vitrectomy before going ahead and putting the glue.
So you will suggest the surgeons that the vitrectomy over the break should be complete and it should be clear, free of vitreous.
It is absolutely same as what we do routinely for our vitrectomies. The only difference is that instead of putting oil or gas, we are using fibrin glue as a tamponade agent. But otherwise also we ensure that we have to make our break area free from vitreous. So even in our normal routine vitrectomies, the same thing over here also.
So basically, Dr. Mudit, especially it will be advantage only in one-eyed patients where you don't want even put gas. That's a specific advantage, right? Where you don't want any tamponade. This is where it scores, this particular technique.
I have kind of doing it in most of my cases which are amenable to the inclusion criteria. And it allows me to give them a very early post-operative visual recovery. Just at the span of 3 to 4 days, they nearly gain the final visual acuity which they would have gained. I don't need to give them any post-operative positioning. I don't have to put any oil or gas. So, Dr. MPS sir has a question, sir's hand. Sir, you are muted.
Yes, Dr. Mudit. Yeah, it's a very elegant technique. I have been following this since you presented this about 3-4 years back. Unfortunately, I did have quite a severe inflammatory reaction in one of my patients. So the patient was actually one-eyed, and like thought we'll give him a earlier rehabilitation during the last year's lockdown times. But then subsequent to that, he had quite a severe inflammation. And then like in the next 3 to 4 days, I had to take him up for a resurgery and then do a routine surgery. And subsequent to that, actually, he lost vision, which he has not regained. So that was one thing which was surprising to me, though it is not supposed to cause anything like that. But it did cause significant inflammation in one of my patients.
Okay, sir. Because I have now done it in around not even 31. 31 are the patients for whom I have got a 6-month follow-up. But now I have done it around 39 patients to be precise. And in none of them I have till now faced a significant inflammation. Only
I have done it once or twice before also, but then like I didn't have any issues. But this particular patient who was a high myope, so and he was one-eyed actually. So I thought of giving him a thing, but then subsequently he had such an inflammatory reaction and did the vitrectomy, and subsequent to that again, like for some reason he has not regained the vision at all. That's one thing. So I'm sure it's a beautiful technique, but then like you keep the patient on a little closer follow-up and make sure that there's no inflammation. That's what I'm saying.
Mudit, I have one question.
Yeah, Tandav.
You did not do any 360-degree laser in these patients. You
Nothing.
Did the laser around the breaks?
No 360-degree laser, nothing. Anyways, even in my vitrectomies, if I have got only 1 or 2 localized breaks, I don't usually do a 360-degree laser. So the same thing over here also. There were 2 breaks or 1 break or 3 breaks located close to each other. I do a laser around them and then I just do that. I did not do a 360-degree laser.
Okay, now we will go on to the next talk in interest of time. I'm sorry to interrupt, but I think we have to keep time. So next talk is by Dr. Mahesh Shanmugam. 2 talks on complex vitreoretinal surgeries. Thank you, Dr. Mahesh Shanmugam, for joining us.
Thank you, Dr. Malika and HOA for giving me this opportunity to meet you all, at least virtually. Hope to see you all in person soon. So in the interest of time, let me get on with my talk. So all of us who are vitreoretinal surgeons are familiar with how our life is, a day-to-day life. Like it's kind of, we are stuck between the hard place, rock and the hard place. That's how our life goes on. So, but what it happens, what it gives rise to is like we have to think on our feet and come up with solutions, sometimes out of the contemporary solutions. So that's what we are looking at in the next few slides. So peeling the hyaloid in myopia can be difficult. As you can see here, the hyaloid is strongly attached and like you don't know what instrument to use. Sometimes you use a Finesse loop, sometimes you use the cutter, sometimes you use the needle. And what we used of late is the PVA sponge, the PVA arrowhead sponge, which is being used by the corneal surgeons. We can actually take a small bit of it, hydrate it, and hold it in a forceps. And this, as you can see, it's got a little rougher surface. So we can identify the vitreous which is stuck onto the surface of the retina, and it aids to peel it as well. So even posterior vitreous and anterior vitreous, particularly in myopic eyes, we can use this to peel it, and it's quite safe. You can touch the retina and peel it quite safely without causing a break. So quite a safe instrument. And the best part of the instrument is like once the job is done, you can eat it with a cutter and remove the instrument from inside the vitreous cavity. So often we come across situations when the break is not visible in the retinal detachment. One option is, of course, to keep searching, or like Dr. Tanda mentioned, you can do a 360-degree blind laser. Like Mudit mentioned, I also don't like to do a blind laser. You would want to see the break and treat it so that like you're comfortable that you've taken care of the primary break. So one of the earlier articles came up with this idea of doing a BBG aided break identification. In that, Dr. Elwood had used a transretinal BBG. So using a 42 gauge cannula or something like that, he has injected transretinal into subretinal space and to identify where the break is. But then this results in a iatrogenic retinotomy, and not all of us have a 42 gauge cannula. So this is the modification which I have. An elderly gentleman. So we did the vitrectomy and depressed and tried looking for the break. We just couldn't find the break. So here what I'm doing is subretinally injecting the BBG using a transretinal, like a transscleral subretinal needle insertion. So the needle goes through the sclera into the subretinal space, and the dye is injected. A bubble of perfluorocarbon is used to roll the retina, and you can see the dye coming out through the break. So you can identify the break and you can treat it. So if you don't have a 42 gauge cannula, you can inject the dye in the subretinal space transsclerally with a 24 gauge needle. Dr. Reis has popularized this technique of suprachoroidal buckling with a viscoelastic solution, and particularly for posterior breaks. And this is a special cannula which is illuminated. This is a video which is his video from the YouTube. But then, like, not all of us have this, and it's a proprietary cannula which is not in on sale here. But can we use this viscoelastic to augment the buckle or create a buckle if we don't have the cannula as well? We can do it for particularly peripheral breaks. So here was a young child who had a focal C1 PVR in this quadrant with the break lifted up. But then the rest of the retina was quite mobile. So I wanted to avoid doing a vitrectomy. So I did a sutureless buckle in the inferior temporal quadrant, and then decided to augment this with the viscoelastic. So we made an opening, and this is the buckle, sutureless buckle. Drain the subretinal fluid to create hypotony. And in addition to the buckle, superior to that, in the suprachoroidal space, we injected viscoelastic, so that like to give a temporarily high buckle effect until the cryo takes effect and the break is sealed. And subsequently, when the retina falls back, it falls back onto the buckle, and the vitreoretinal traction is relieved by the buckle as such. So this viscoelastic buckle doesn't all the time require the cannula. Peripheral breaks, we can use it with the existing equipment which we have as well. This was a young lady who had SLE associated combined retinal detachment. You can see quite a particularly bad eye. There's hardly any posterior vitreous detachment and particularly vascular proliferation. So I was wondering if the PVD can be created easily at all or not. So in selective cases, we use this autologous plasmid, which is a described technique, pretty old technique. So here we gave anti-VEGF were 3 days earlier, and an autologous plasmid was prepared on the day of surgery and injected in the morning. About 2 to 3 hours later, we took her up for surgery. And this is the surgery. As you can see, it's a nasty looking proliferation extending anterior to the equator. Quite a large proliferation. Fortunately, after anti-VEGF, the vascularization has become regressed, and we created a posterior opening, and using the viscoelastic aided dissection of the posterior hyaloid in certain places. And I was expecting that I'll be doing a bimanual surgery, but probably because of the plasmin and the anti-VEGF, and probably the retina was reasonably healthy because she was young, we managed to do the complete surgery with a unimanual technique itself. You can see how the hyaloid is peeling off reasonably well. And so in particularly nasty looking proliferations, I do use this autologous plasmid. So you can see the proliferation is extending pretty much anterior as well, anterior to the equator also. And this is the last part of the proliferation which is being peeled and removed. Not much of bleeding as well. And that's the proliferation over the disc and nasal part. And here again, like I use a transcleral drainage. I couldn't find any break, though I suspected to be commendable attachment. So here again, transclerally, I'm draining the subretinal fluid. I didn't want to create an iatrogenic break to drain the retinotomy, to drainage the retinotomy and reattach the retina. And this is the post-op appearance, pre and post-op appearance. Had another one-eyed patient, high myope, who had undergone a vitrectomy elsewhere and was sent to me for silicon oil removal. The issue was he was a myope, high myope with the myopic schisis, and what we see here was the myopic schisis was open and there was emulsified silicon oil within the myopic schisis and in the subretinal space in the macular region. And this was the only eye of the patient. So I was left wondering what I should be doing. So we used triamcinolone to see if the hyaloid was removed or hyaloid was still intact. You can see that the hyaloid is actually intact. So myopes, we need to be particularly careful. Even in experienced hands, we can miss the sciatic posterior hyaloid. And then I found that there was a break along the inferior temporal quadrant. So we used a bubble of perfluorocarbon. Then you rolled it to roll that little bit of emulsified oil towards the break, removed it, then had to remove the perfluorocarbon, then redo it. So whatever bubbles are superior to the perfluorocarbon, which is loculated there and is not able to communicate to the break. So once the perfluorocarbon is removed, then some amount of bubbles come towards the break, then use a perfluorocarbon to roll it. So this rolling technique, what we used to do to remove the subretinal hemorrhage is what I used here. Multiple times I had to repeat this cycle of removing the perfluorocarbon, putting it back, and then rolling it. So even after doing the laser, once again, I do use perfluorocarbon to try to squeeze out as much of this emulsified bubbles which are within the sciatic area as well as in the subretinal space. And this is the post-op appearance. So you can see the retina is attached. Unfortunately, most of the subretinal emulsified oil we managed to remove, and he got back some useful vision. There was a young boy who was once again one-eyed, and he had this coloboma in one eye. The eye was lost, and he had this colobomatous disc with the break here. I had already done about 3 vitrectomies, and he used to be okay for a few days and then develop a recurrence. And subsequently, yet again, he came back with a recurrence, and the oil had gone subretinally, and this is the superior retinotomy, and the oil is being removed. The problem is the break close to the disc. So which, despite doing laser, it just wouldn't keep the retina attached, and it will leak and keep on recurring. So remove the oil and put the retina back. So I was wondering what to do to close that defect. So amniotic membrane was a possibility, and like the internal limiting membrane wouldn't have worked. So here I used this gel foam, so gelatin foam, which we had used once earlier to plug a scleral defect. So this is what we stuffed in that defect, the colobomatous defect close to the disc. So ultimately 3 surgeries didn't work, and after this his retina is attached and he continues to hold on to this. This was a high myope. This was one eye which he had undergone about like 5-6 surgeries elsewhere and was lost. And this eye again, like in another institution, he had about 3 surgeries and came back with recurrent detachment. You can see the extensive scarring because of laser photocoagulation, and the macula was detached. Once again, like he had about count figures close to face vision, and he had this membrane. So I went ahead and did the revitrectomy and used Densiron and membrane peeling, but that didn't work. And subsequently did a subretinal fluid drainage and endolaser, and the retina was attached for some time, but that didn't work either. And he developed recurrent retinal attachment post-op. So there was a third or fourth surgery I had done, and he had already had about 4 surgeries elsewhere. I was wondering what was happening. Ultimately, figured out that the break was within this area. So this area, whatever, and there was a staphylomatous eye, so it was lifted up and wouldn't allow the retina to reattach. So, and a vitrectomy technique is not going to work. So ultimately what I did was to use a T-shaped buckle and elevate this portion from outside. It's a macular buckle, which is what used for the macula, but we used it for a posterior like choroidal atrophy with a break within. And subsequently that did the trick, and the retina continues to remain attached, and he has about like ambulant vision of 636 and is gainfully employed as well. This was the last patient, and this gentleman had had a surgery for a macular detachment in the left eye. So he had undergone vitrectomy and silicone oil injection. And before that, actually had a gas also, and then it occurred, and the surgeon had put this silicone oil injection, and subsequently presented to the doctor with headache, with loss of vision in the normal right eye. So the surgeon did the visual fields and found that he had the patient had a hemianopia and had an MRI. And the radiologist came up with this. So this was silicone oil in the operated left eye, and the silicone oil was in the chiasm. So it had migrated into the chiasm. And because the patient had relatives in Bangalore, he was referred to me. And subsequently, this is the surgery that was done. Of course, this is not a surgery which we are doing it. This is a surgeon, one of my friends, the neurosurgeon who is doing it. What we see here is the chiasm. On the left side of the chiasm, we made an opening, and the silicone oil, what you see, the silicone oil which was loculated in the chiasm coming out. So this is the first time and probably the last time I found the neurosurgeon doing silicone oil removal instead of a vitreoretinal surgery. Unfortunately for the patient, the visual fields improved subsequent to the surgery. So it's an interesting life that we lead as vitreoretinal surgeons, and I hope that like some of these cases appeal to your interest as well. Thank you very much.
Dr. Shanmugam, maybe we can go on with the next talk as well.
Sure, I'll go ahead.
We can keep all the discussion at the end of the 2 talks.
Okay. There are 2 types of ocular oncologists in the country. One are people who are trained in oculoplastic surgery, and the other best group is us, who are doing vitreoretinal surgery as well as take care of intraocular tumors. So this once again results in challenging situations, which is what we will see in the next few slides. Vitreoretinal surgery is often required in intraocular tumors. It could be for diagnostic purposes where you do a biopsy. It could be a fine needle aspiration biopsy or a vitreoretinal biopsy of the vitreous or the tumor per se. Or it could be therapeutic to treat the tumor per se, or to treat the complications because of the tumor to regain some vision. Let's start with vitreous biopsy. The commonest indication for vitreous biopsy is primary intraocular lymphoma.
So sorry to interrupt. So can you just share the screen again, please, for the second case?
So you couldn't see from the beginning, or where do I start?
Beginning,
Yes.
in the beginning.
Okay, sure.
Thank you.
So as I mentioned, like the techniques in intraocular tumors, either for diagnostic purposes or therapeutic purposes, the commonest indication is vitreous biopsy. The classic indication is primary intraocular lymphoma, and it's essentially just a regular vitrectomy is what we would do. Only changes are we use a low cut rate so that we do not macerate the cells, and also stop the steroids about 2 weeks prior. Otherwise, it's likely that the biopsy is likely to be negative as well. And best is to liaise with the pathologist and talk to them about how they want the specimen sent, so that like we don't, whatever little specimen we have, we make sure that it reaches the pathologist in time. And it's not it's not an uncontaminated specimen or anything like that. We turn on the fluid and do a complete vitrectomy, and the whole vitreous is what is sent as a specimen. So fine needle aspiration biopsy can be done either with indirect ophthalmoscope, and sometimes I do like the vitrectomy technique where I've done a vitrectomy, and this is the biopsy part of it. A 24 gauge needle is plunged into the mass and aspirated. You will not see any aspirate coming into the syringe, because that little sliver of tissue which is in the bore of the needle is what we would send for what we get. So once it is plunged inside and brought back into the vitreous cavity, then we aspirate the fluid in the vitreous cavity, and the little sliver of tissue which is there in the needle will come into the bore of the syringe, and then we send it along for the biopsy. Of course, without a vitrectomy, we can do it with the indirect ophthalmoscope. So, and most often that break doesn't result in a retinal detachment. And very rarely we may have to do biopsy in a small, very small lesion. So here this was a melanocytoma of the optic nerve head which appeared to be growing, and we needed to know if it was indeed a melanocytoma or a melanoma. So this is a vitrectomy technique where we have done the vitrectomy, induced the postvitreous detachment, and we cannot plunge the needle inside. So there was a capsule covering the tumor which was being opened up, and a little bit of the tumor is loosened up from the main tumor. And once a sufficient tissue is mobilized, we grasp it with the forceps and we give this up. When the forceps comes out, usually we switch off the infusion so that there's no intraocular pressure is not high to push any tumor cells outside. Make the eye a little soft once the tissue is removed, and then we go back to doing fluid direction and closing it. Moving on to therapeutic, it could be vitrectomy techniques could be to treat the tumors or an excisional biopsy. This was a young gentleman who presented with this mass lesion on the nasal side of the sclera, which was growing and was showing a mass effect inside the vitreous cavity. We did an incisional biopsy which showed a very rare lesion, what we call as a schwannoma, which is usually a suprachoroidal tumor. So here the buckling techniques came into play. So we created a trapdoor, a full thickness trapdoor had to be created. So what we see here, this is the area where I had taken the incisional biopsy. So here you can see the whole sclera is peeled off from the uvea or the choroid. So this is the mass lesion and this is the normal choroid. The sclera was freed from the suprachoroidal schwannoma, and the schwannoma was peeled off from the uvea. So fortunately, it didn't have any rupture of the uvea or loss of vitreous. They used the endocrine probe to hold on to the tumor and resect it off from the uvea. So in the meantime, the site where I had done the incisional biopsy had opened up. So this is the site where the incisional biopsy was done. So that area of the sclera was also closed up. So there were no retinal breaks or choroidal breaks. We are at the end of the surgery. And this is the result about 3 to 4 months later. He continues to have 6/6 vision and no recurrence of the lesion. This was an elderly lady with an iris melanoma, what we see here. So a patient had some amount of cataract. We removed it and decided to put an endocapsular ring because this area of the zonules is going to lose its support. The bag is going to lose its support once I resect the tumor. So here, instead of a full thickness scleral flap, we use a partial thickness scleral flap. Vitreoretinal instruments are used to create an iridectomy. So I didn't want to do a sector iridectomy. Peripheral iridectomy is what I created with about 3 millimeters clearance from the tumor. And the iris, the tumor, the sclera, and the ciliary body is removed in toto. So we enter the anterior chamber. After diathermy, we have opened up into the eye. That's the residue of the sclera along with the tumor. The iridociliary tumor is removed, and open sky vitrectomy is done, and the flap is closed. We would often do vitrectomy to manage the complications, and it could be a very, very simple surgery like this. This patient had an epiretinal membrane secondary to a peripheral solitary retinal angioma. So there's nothing great about this particular surgery. You just remove the epiretinal membrane. Then, of course, we peel the ILM. If you don't peel the ILM, you're not a vitreoretinal surgeon anymore. And it's standard surgery, nothing different. The only difference is that this was the peripheral tumor. So did a double freeze stock cryo, so allow the ice ball to engulf the tumor completely and thaw. So this is what we do in this particular patient. But much more complicated angiomas is what we find often. So this is a peripapillary tumor with a lot of exudative retinal detachment and retinoschisis. So here we had to drain the subretinal fluid. Again, a transscleral needle drainage technique is what I'm using. You can see the bevel of the needle facing towards the RPE. And the vitrectomy was not done in this patient. So we just drained the fluid. And though we are using an endolite pipe and a biome, a vitrectomy was not done because that's not really necessary, and used other active port to do laser to the peripapillary angioma. Some amount of this chytic fluid remained, but the subretinal fluid could be drained. Traction retinal detachment is once again a side effect of vascular tumors, particularly of the retina, particularly the angiomatous retinae. So there was an angioma which was treated, and you can see the significant scarring. And organized vitreous, and you can see the macular traction retinal detachment with a lot of exudates under the retina. So the traction bands are removed, and very, very careful vitrectomy not to create breaks and to remove all this fibrous tissue is what is done. So you can see a very gentle, very careful vitrectomy is being done to create islands of this fibrous tissue and not to create a break. And this is the post-op appearance. The traction retinal detachment is resolved and the tumor also has regressed. Often we do come across regmodosa retinal detachment as well. This is one such patient. I did a sutureless buckle supporting the peripheral angioma. So he had a macular hole in addition to a peripheral angioma. This is a family of VHL patients. So this is the angioma in the periphery. So I thought like the initial plan was to support the angioma and reattach the retina. So the macular hole had to be tackled. So we're staining under the perfluorocarbon liquid and to peel the ILM. We kind of stuffed the ILM. So this is the peripheral angioma which is being removed. I thought like the buckle will suffice, but there was significant scarring. I knew that like the buckle will not suffice, and this is one of the rare situations where the fibrous tissue on the angioma was being resected. This is a phakic patient. The lens is in place, so this is a phakic base excision, which is what I'm doing. Larger tumors, what is my preference is to do a brachytherapy, regress the tumor, and support it with a broad buckle, not to resect it, because resection looks very nice on videos, but very often what happens, severe scarring happens and the eye becomes thysical. So off late, we are doing very, very carefully in selected patients of retinoblastoma who have active disease, one-eyed patients with a regmodosa retinal detachment. Failing with this eye is also likely to be lost, and the child may end up bilaterally being blind. So there is one such patient referred from elsewhere after having undergone treatment for retinoblastoma. The other eye had been enucleated, so the child had a regmodosa retinal detachment. So using special techniques where we avoid spillage of the tumor outside, use melphalan or topotecan and infusion. Distilled water is known to kill retinoblastoma cells, so that's what I'm using in the subretinal space. Under cover of systemic chemotherapy and sometimes external beam radiation treatment, very selective patients undergo vitrectomy for regmodosa retinal detachment associated with retinoblastoma. So last of my cases where we may have to do vitrectomy for clearing the vitreous. This is one such interesting patient. So you can see the whole vitreous is filled with pigment. So just so much of clumps of pigment which was there. So I was wondering what it was, but actually it's not a melanoma. It was a melanocytoma of the ciliary body. Surprisingly, it was in the elderly lady. So this was the tumor somewhere here. So which had undergone necrosis and filled the eye completely with pigmented debris. So which is what we removed, and she got back very good vision. So this is the melanocytoma what we see here. So to summarize, the vitreoretinal surgery for intraocular tumors could be to get a biopsy specimen. It could be FNAB or vitrectomy. Benign lesions we can excise as well. It could be therapeutic to treat the tumor or to treat the associated complications. Primary malignant intraocular lesions, anterior tumors can be excised, like we saw in the case of the anterior iridociliary melanoma. And vitreoretinal surgery to manage complications in the presence of malignant intraocular lesions, we need to be particularly cautious, particularly in case of a retinoblastoma. Thank you very much once again for the opportunity.
Wow. Excellent. It's mind-blowing. I think everybody's stunned right now.
Yeah, I have a question, sir. Excellent video, sir. Yeah, hats off. I was just wondering, how do you prepare this? How do you prepare this autologous plasmin? Do you have a tie-up with somebody else? Or?
No. You can prepare it yourself. So you can draw the blood from the patient and give it to your own lab if you have a lab. It's centrifuged and the plasma is taken. And a particular amount of urokinase or streptokinase has to be added to centrifuge it. That's all. It's a very old article. If you can Google it, it will be there. Otherwise, I'll send it across to you in a private thing. So you can prepare it in your own lab.
What is the exact purpose that the plasmin is serving in that particular case?
The vitreoretinal adhesion is supposed to lyse. So people have actually used for ROP surgery also, but I have not used it. So densely attached vitreoretinal adhesions, it can make it a bit looser, where it aids your surgery.
How many hours would you suggest before the surgery?
Usually about 3 hours before is fine. Sometimes I have injected the day before also, but sometimes it can induce an inflammatory reaction, because main thing is the sterility part of it, because you're poking the patient and drawing the blood, and then taking it to the lab. So the lab technicians are not usually bothered much about the sterility part of it. So one of my fellows goes along and makes sure it's absolutely sterile. So that's the part of it. So that's why it's better to inject in the morning and take it up in about 3 hours surgery.
Yeah, Dr. Tracy does it after doing a micro lab evaluation. He sends one piece there and then injects about 4 hours before the surgery for ROP.
Yeah, if that's possible, that will be great if it's possible.
For the viscodissection, which viscoelastic do you use for the viscodissection?
Anything, like I usually use the Apavisc, which is available. So it's something which flows, which is not a cohesive viscoelastic, what I would use.
So can we use TPA instead of plasmin?
Yeah, you can use. Only problem is whether it will cause more bleeding subsequently, because TPA is supposed to lyse clots. So if it remains there and if you're having clots blocking your bleeders intraoperatively, whether it will lyse or it will not allow them to lyse, and whether it will continue to have bleeding is the question.
No, with
so
combination of anti-VEGF. With combination of anti-VEGF for 3 days or 4 days prior to the surgery.
You can. I have used TPA only in the presence of subretinal clots, and one patient with large preretinal clots I have used, but not to lyse the membranes. I am not too sure if it makes it easier. Or not lyse the membranes, the vitreoretinal adjacent, whether it can make it easier to remove, I am not too sure.
And the visco which you used to support the brake over the buckle,
yes.
What visco was that?
This one you can use the cohesive, something like the Orogel, which lasts a little longer. In fact, like I think I have Beltrace, he uses Restylane, which is the filler. So that lasts for about a year and a half. So you can use a little thicker viscoelastic, which lasts for a little longer time. So I would usually use the Orogel, which probably lasts for about 2 to 3 weeks. I just need it for that long, that's all.
So sir, in that particular case where you put visco gel, you also put in a buckle, right? Buckle and a gel.
Yeah, I have used only, because in the interest of time, I have not shown the other video where I used only the gel. In 2 different places, 2 different breaks, I used 2 different areas of visco.
Okay.
But in this particular child, in that quadrant, there was a fixed fold which was lifting up the retina so high, I needed a higher buckle in that area. That's why I used visco plus a buckle. Otherwise, you can use only visco also.
Thank you.
So Mahesh, wonderful videos, mind-boggling in fact. So in patients who have no break, reg-looking RD, how many times you have been successful in locating breaks with this BBG technique?
I would agree that like not all the time, but then like if the retina is reasonably mobile, and if you're able to get a reasonable amount of dye under the subretinal space, then it is possible. So if there is not a large break, it's a tiny break, by rolling it after the PVD, then we should be able to localize it. So the key is it should diffuse into the subretinal space, the dye, and the retina is so mobile that like when you're putting the perfluorocarbon and rolling it, it should be the fluid should move to all the quadrants, in which case we should be able to find out.
Is there any particular location where you choose this transscleral drainage?
It depends on which hand you're comfortable with and which eye you're operating with. So I'm usually comfortable with my right hand. So it's usually my right hand. And it depends on like the left hand shows the light, and usually in the nasal quadrant or temporal quadrant, closer to the horizontal meridian, I'll depress. You can see the depression effect inside and enter the subretinal space tangentially with the bevel facing down. So that's how it is. And like, because it's a pressurized compartment, doesn't bleed even if you go close to the vertex line, but I would prefer keeping it away from the vertex line.
Means around 6 mm from the vora? You will
like you don't have to really measure it. So if you open the conjunctiva, then you can obviously go post it to the muzzle ring. And because of depression, you know where the tip is.
Okay.
So you just enter tangentially. But like sometimes in Coats disease, I do transconjunctival. So in that, I just go into the cul-de-sac and go inside. That's all. So you don't have to really measure. I don't measure. But you can Coats, the retina is right behind the lens. It's okay. But in other cases, you can depress and see the tip and enter. You can literally see it very gently using in the subretinal space.
You're using the 26 gauge needle itself, sir, for external drainage? Which gauge
24
needle?
or a 26, a 1-inch needle is what I would use, because longer than that, it's difficult to control. 1 inch with the plunger off in a 2cc syringe is what I would use.
You showed some a sponge for cleaning out the vitreous, for shaving off the vitreous.
Correct.
Is that commercially available?
This is the same that arrowhead sponge which the cornea surgeons use. That's what that is called a PVS sponge. Actually, it's not our techniques are described by in one paper earlier, but then like our modification was the using in the forceps and eating it inside the eye. So this is the same sponge, the arrowhead sponge, which is used to absorb fluid. The cornea surgeons, LASIK surgeons use. So wet it and take a small bit of it and use it. That's what it is.
Wonderful. That's wonderful. And the gel foam which you used to seal a defect, was that commercially available? The gel
That's
foam?
again commercially available. It's available in any OT. We have it because like when I do enucleation, sometimes it bleeds. I used to stuff it in the optic canal. So that's the reason I have it in the OT. So one of my colleagues, actually, he had a rupture of this sclera intraoperatively, and everything what he was putting inside was going outside. So he was wondering what to do, and then use the gel foam to stuff that, and that stopped it. So that's when we knew that it was reasonably safe to use it inside. So in this patient, we used that. So it's again like it's hardly, it's about 50 rupees, 100 rupees, something like that. That's what it is.
Excellent, excellent.
But do we have to remove the port, sir, before inserting that gel foam inside, or with the same port we can go inside?
In this, I did, like, it depends on the size, right? A gel foam I did, it depends on the size you want to put it inside. Okay. So if it's a little larger gel foam you want to put, and you cannot obviously put it through a 25 gauge or a 23 gauge. So in that case, you may have to remove the cannula and then put it inside and then stuff it inside. So it depends on the size of the defect.
So in the interest of time, we'll move on to the next talk.
Thank you, Dr. Mallika.
Shanmugam, really obliged. Thank you very much.
Thank you.
Next talk by Dr. Lalit Verma. The talk is enigmatically titled Retina Scuffle. So, welcome, Dr. Verma. Thank you very much on behalf of HOA.
I'll just share my screen now. So, thank you, Mallika, once again for having me in this wonderful program. In fact, the video shown by Mahesh for mesmerizing. Thank the entire HOA team for designing this wonderful program and an opportunity to meet Dr. Huang also. So this word scuffle means struggle. So what I believe is that all of us, you see all these challenging cases which Mahesh had shown, but all the VEER surgeries are different. None of the patients may be identical. And a lot of these patients want to join back, and it was very interesting to see Mudit's technique of, modifying the VEER surgery so that these people can join back fast. And patient demands and expectations are increasing. They want to join back the vitreous very fast, and consumer courts are on your head. Also, you see at times we are confused peroperatively, or we are in a dilemma. And any awkward movement, or you see a couple of days back, my staff nurse not in a good mood, so we had a disaster. So all these things you have to face day in and day out, and there is a constant struggle, and this can be realized only by a VEER surgeon. And I believe every VEER surgeon is a fight, and this fight is for success, for the anatomical success for the patient and also for us. And the day I do not succeed in surgery, it's a restless night for me. And as I said, no one can realize the pain or the stress. The least of them, the anterior segment surgeons, will never realize the stress which VEER surgeon undergoes every day. So I have this couple of videos which I thought I'll share with you. And for all of you, I think this may be routine facing these challenges. But this is one patient who had anterior uveitis. Who had anterior uveitis, you can see pigmentation on the surface of lens. And we entered in a routine way tangentially. And this was the situation as soon as we entered the vitreous cavity. This cannula was subretinal here, and retina was balloonous. You see, preoperatively, retina was not balloonous. And there were a couple of breaks which you can see inferiorly, with a lot of muck in the vitreous, densely adherent vitreous. And I could hardly do vitrectomy, therefore I injected PFCL just to separate these two balloons so that I may be able to do some vitrectomy at least. So at this point of time, I thought of shifting because this light pipe and came closer to the cutter. There was a struggle between the two instrumentation, the clutter of instrumentations. Still, mind you, I was not able to manage a complete vitrectomy because of the sticky vitreous in this inflamed eye. And whatever vitrectomy I could do, I managed this membrane dissection also bimanually. And in the process, a couple of iatrogenic breaks also got created. So after having done most of the vitrectomy and diathermizing, PF seal was obviously used in between to separate out these big balloons, and retina was becoming balloonous. And here comes the subretinal air at this stage. So I shifted the infusion canal also. Now you have 5 entries into the globe. This time I went absolutely straight into the globe, no tangential entry at all. And this is when I took out this subretinal air with the help of this needle. Subretinal air came out, and obviously base dissection in this patient was not completed. And only after air-filled eye I could manage some base dissection. So after this was done, the retina became reasonably mobile, and we could settle the retina with the usual technique, and then laser all the previous breaks and iatrogenic breaks also. This was the post-op picture. This was another patient where a couple of surgeries had been done before, and patient presented with a recurrent RD with PVR. And my favorite instrument is a 25 gauge MVR blade, sharp blade, to dissect a plane and take this membrane, have the edge of the membrane identified, and after the edge is identified, usually we have a forceps. And this was densely adherent membrane because I think multiple surgeries, multiple episodes of inflammation. But what wrong was done here was that excessive pull was applied. And this pull resulted in the formation of another iatrogenic break, which was very big in size. You see, there was this sign here, hemorrhages occurring on the surface of retina, and more pull and a huge break was created here. And immediately there was panic everywhere because all your fellows are seeing on the screen. And so don't panic at this stage. Membrane is still there. So I try to free these edges of the membrane. Obviously, you can't pull more because there's already a iatrogenic complication there. And this was a struggle going on in my mind what to do next. And what I thought was I'll go bimanually to cut this membrane. So inserted a chandelier here. Pupil was getting smaller at this stage. And then with the help of scissors, dissected this membrane and freed the retinal surface at this place. And then did some diathermy over it. Fortunately, there was not a, but this was not the end of it. There was further membranes in the periphery. So this time, obviously, had to be very, very gentle because once a break occurs, you see, then pulling forces have to be very, very gentle. So this time, with the help of MVR blade along the entire tangential surface of the retina, I freed this membrane before exerting a pull over this membrane. And this was responsive in the sense that this PVR membrane slowly, steadily, very gently, because it was difficult to put the scissors here to take off this membrane from the periphery. And this was that iatrogenic break which we had created. So after releasing all the PVR membranes, then this patient, we did the routine previous surgery, choroidal adhesion marks are there. And then we put in the silicone oil and did laser photocoagulation. This was another patient who had this subretinal hemorrhage. You see, as soon as I started vitrectomy, I noticed that patient had a subretinal hemorrhage. So aim was to either remove it or leave it because it was away from the macula. So what I did was I made a iatrogenic retinotomy here and tried to, because this was half an hour into the surgery already, so I thought this will clot and form a subretinal scar. So I created a retinotomy and with the help of active suction, pulled this clot out, and fortunately it came out. But still a lot was still, there. So what I noticed here was a track in this patient. It was a, high myope patient, and there's a track. I thought it was a needle perforation which happened during the block. And then I made one more retinotomy here, and aim was to remove this entire coagulum, because in the first time I was successful in removing part of the clot, but here, fortunately for me, this again came out. This coagulum from the subretinal place, slowly, steadily again going to the base of that clot. And fortunately, this entire clot came out, and then we finished the surgery as usual. So this was another patient, young patient, 18-year-old, had, so I used a belt buckle in this. I could not see any break pre-operatively in this patient, so I put a belt buckle here and started the vitrectomy. And as we know, in all young patients, this vitreous is very, very sticky. So despite usage of tricot, we could not, and then put this PFCL to separate the balloons, because the retina was becoming balloonous. And then put this PFCL bubble and try to decrease the height. You see, Shanmugam showed external drainage. I did it from internally, tried to make retinotomy and decrease the height of this, but could not successfully do the entire vitrectomy, and tried to do air fluid exchange. You see, after doing the air fluid exchange, I took this diamond dusted, which has diamonds, just as a rough surface, and then in the infranasal quadrant, identified this huge sheet, which successfully came off, and even the retinal fold that was there in the macular area got flattened after this, this sheet, as you can see, came off under air. So the sticky vitreous is a issue in youthful, eyes, where it may be difficult to peel off the membranes. So ultimately, this patient did well, and we removed the oil also. Patient recovered 6/18 vision in this patient. So this is the last video there, which was simple looking giant retinal tear. And this patient had pre-operatively very good vision, macula is attached, but the flap was rolled. It's very important, as you all know, to go to the base and shave off this vitreous, especially from the edges of the tear, and do the conventional technique of GRT management. Fill up the cavity with PFCL and do all the usual techniques, to eat away this anterior flap of the GRT, and do laser photocoagulation, especially at the edges, and do multiple rows of laser photocoagulation. And I was pretty happy. The only thing was that, you see, the issue was that the GRT had become a cleft-like. It was so anterior that I could not position my flute needle into the cleft. So I noticed that there is a slippage of the tear here. So there is a fluid collection again. The option was to go back, but I made a small retinotomy there and took out the fluid from there, and then did the laser photocoagulation posterior to the edge of GRT, and also included this break you can see here. So fortunately, patient maintained his pre-operative vision after the oil removal also. So these were a couple of patients which I thought, I will share this in another video. I'll skip for the sake of time. So these were a couple of videos which I thought, keep us on the alert and on the job. And as I said in the beginning, no two surgeries are same, and every VR surgery is a fight for success, and nobody realizes the stress which we undergo virtually every day. Thank you very much for giving this opportunity.
Wonderful videos. My heart was stopping at many points. Dr. Padmaja, would you like to have any questions?
Malika can't hear. Can you hear?
Yeah, okay. Excellent. So very heart-stopping, actually. In some of these situations are really heart-stopping.
Hello.
Yeah, excellent videos, sir. As always, it's a joy to watch them. So one.
Hello.
Hello, can you hear me?
Yeah, we are hearing you.
Can hear you.
Probably there must be.
So one aspect
Lalit.
I thought those thin membranes, sometimes even a brilliant blue, I feel that.
Can you hear Malika?
Yeah, we can hear.
Yeah, we are hearing you.
No, I am not able to hear.
Your volume, you have to turn up the volume of your computer.
I don't know whether you heard my talk or not. I don't know.
Yeah, we could hear very clearly, Lalit. Don't worry.
So shall I try relogging or because?
No.
You're logged in, sir.
Can you hear us or not? Sir, can you hear us?
He left and he will log in again. He's reconnecting. He's reconnecting. Wait.
Yeah, he has to also introduce Dr. Huang.
I know. He joined anyhow.
Yeah.
Has he joined?
Yeah. Lalit?
Hello?
Yeah. Lalit? Yeah, we can
Still
see
can't
you.
hear. I don't know what is the issue. I'll try relogging.
Yeah, we could hear.
I'll try relogging because I don't know. Something has happened to his sound system. Can't
Are
hear.
you able to hear us now? Are you able to hear us? No, I think what we'll do is we'll move on with the program.
Yeah.
I'll move on with introduction for Dr. Huang. I'd like to welcome Dr. Subair Huang, who's here with us now from he's a very illustrious personality, and I was thinking an equally illustrious person to introduce him. But Dr. Lalit Verma's audiovisual has failed at the last minute. So Dr. Huang, on behalf of HOA, I would like to welcome you. Dr. Subair Huang is the CEO of the Retina Center of Ohio, and he's also attached to the Bascom Palmer Eye Institute. He's the chair of the National Eye Institute and the NIH National High Eye Health Education. He's the AAO representative to the United States Pharmacopoeia, and he's the chair of the Research, Regulatory, and External Scientific Affairs Committee. He's the current chair of the Compounding Pharmacy Task Force. He has an illustrious training and background, has received his undergraduate degree at the Johns Hopkins University, and did his ophthalmology residency at the Wilmer Eye Institute. He's done his fellowship in vitreoretinal diseases and surgery from the Bascom Palmer Eye Institute, and subsequently received his graduate training at the Harvard University. He's currently he has founded the Retina Image Bank, which is the world's largest and most comprehensive open access multimedia database of all things retina, with several thousands of images contributed. It has linked all the retina expertise around the world and has been accessed by countries that represent more than 99% of the world's population. Actually, whenever you need to know something in the retina, if you just put in the name on the Google search and click for images, that's where you get your images from, the Retina Image Bank. He's the editor for the Asia Pacific Journal and the chair of the Asia Pacific Academy of Ophthalmology Retina Vitreous Online Education, the founding officer of the Retina Global, and the editor-in-chief of the ASRS Retina Atlas. He's the president of the Future Vision Foundation, which does powerful research through documentaries of discovery, impact, and hope. He's held several leadership positions and has participated in numerous clinical trials as the chief investigator. He's published widely and has been the program chair for the retina surgery for the APAO and the ASRS Retina Subspecialty Days. His active research interests in surgical innovation, gene therapy, and immunoregulatory properties of stem cells and the epigenomics. He's received several awards and honors, chiefly the Top Doctors and the Best Doctors in America award every year since 2003. the American Academy of Ophthalmology Secretariat Award twice, the AO and ASRS Senior Achievement and Honor Awards, and several awards. The list could go on. In 2017, importantly, he has been inducted to the Retina Hall of Fame and has produced a documentary, The 7 Years of Darkness, which was won an award at the National Short Film Festival. He has several academic appointments, and it's our honor to welcome Dr. Zubair Huang to this meeting. Welcome, Dr. Huang.
Sorry, Malika, I had a small glitch, but sorted out.
No problem, sir. Thank you very much.
I hope you could hear. I don't know whether I wasted my talk or.
We could hear you. Only you could not hear us.
Achha, okay, thank you.
Is Dr. Huang here?
Dr. Huang just left me. I don't know. Maybe
I just saw his this thing.
I think his Wi-Fi has had some problem in the beginning, so that might be the issue. Maybe we can take the few discussion questions we had for Dr. Verma now.
Yeah. Probably, Malika, you can tell Rohit to help Zubair. In the meantime, we can take up the discussion questions with Lalit. Lalit.
Yeah.
In your first video, the subretinal placement of the cannula with 23 or 25 gauge, what we can do is, while checking itself, if it is subretinal, we can, the infusion fluid, we can use the other ports.
Yeah, I did that. You see, I had checked the I had checked the infratemporal cannula. It was in the, otherwise I won't start. But you see, pre-operatively, honestly, this patient only had a nasal RD. So the mistake I did was that for 2 weeks, patient, because of COVID, did not come. This RD had become balloonous. So I saw him on the table itself. So this was one, mistake which I didn't tell at that time. So retina, there were 2 balloons which are coming. So I made the port, saw the actually infusion, but this balloonous nature kept increasing. And initial intravitreal could become subretinal as the balloons increase. That is possible.
Yes.
So therefore, I had to change. Other important thing is message is that if you see subretinal, like my light pipe was subretinal, do not keep pushing your light pipe inside, otherwise you may create havoc at that time.
Yeah.
So fortunately for me, we could save this eye, and now the patient is doing well, and we have removed the oil also.
So that video of PVD induction under air is amazing. It's a good technique.
You see, I was so
I haven't seen that much before.
So we keep hearing about this pneumatic vitrectomy. This patient, 18-year-old, had frustrated so much that, you see, retina was balloonous. If break was visible, I would have attempted a external surgery only. But the issue was there was no break at all. So either I would have done a 360-degree buckle, which I'm dead against. So I thought I'll go inside, but this vitreous was so sticky that I was kept, searching for the hyaloid, this thing. So, but I could not. So in the infranasal part, somehow, luckily, because of those, diamond duster, it engaged, and then I didn't leave it and kept pulling. So fortunately, it came out.
I think Dr. Huang is with us.
Young myopic eyes, Lalit,
yeah,
we can use triamcinolone multiple times, so that the PVD can be.
Absolutely. You see, the issue here was, once the instruments are inside, I don't want to come out because there's hardly any space to work. That is the issue.
I know.
So I think we'll welcome Dr. Huang for, we have been waiting for him for a very long time. So welcome Dr. Huang once again. And we are eager to hear your talk.
Thank you. Can you hear me?
Yeah.
Yeah, fantastic. I have a very unstable connection. And now that you know what I look like, I'm going to stop my video so you don't have to, so we can save bandwidth. I've been very impressed with this morning's talks, and your surgeries, sir, were fantastic. Dr. Goyal, thank you for the very generous and lengthy introduction. It gave me time to reconnect, and hopefully I will stay on a bit longer for the duration. I'll share my screen, and we'll begin with the presentation. So this morning, or this evening rather, I would like to speak about a topic that's a little bit more unusual than what we normally have, and that's to talk about complications of anti-VEGF therapy for retinal disease. We are living in a revolutionary time, not only of surgery, but of pharmacologic, genomic, metabolomic interventions, and we're looking to treat eyes with disease in ways that we never have before. So I want to talk about just one very, very small aspect of this treatment and to investigate a note of caution, an area where we look at complications. Here are my financial disclosures. I have no financial interest in this, but I've served as the chair of the Data Monitoring Committee for several important studies, including regenerative patch technologies, which is a stem cell-based research project, for the Argus 2 and the Orion cortical implant device, and also chair the compounding pharmacy committee for the American Academy of Ophthalmology. So we know a lot about angiogenesis. I was very privileged to work in Judah Folkman's lab at Harvard when I was studying for my PhD, along with Bill Gates and Matt Damon and a number of very famous people. I'm also a Harvard dropout to go to medical school and to find my true calling in ophthalmology. But working in a lab that was associated with Dr. Folkman, we'd understand that the original factor, tumor angiogenesis factor, TAF, was first noted because of its ability to promote permeability, and that those tumors who express tumor angiogenesis factor frequently develop serous detachment. So it became very much of a calling card to understand what became vascular endothelial growth factor does, which is increase permeability. Since then, we've known that it is involved in every aspect of angiogenesis, new vessel formation, and also that inflammation is involved. So blocking vascular endothelial growth factor as a technique has been very, very powerful, but it's at a very end stage phenomenon. We know there are multiple entry points and multiple molecular targets that can be used for therapeutic interventions, growth factor signaling, inflammation, looking at permeability, and all the areas in between as illustrated in this cartoon. We also know, of course, that there are many parts of the endothelium and the capillaries that we tend to focus on, not only the role of Brooks membrane in macular degeneration, but how do tubes elongate? What is the damage to the extracellular matrix? How do integrins work? How do we block the receptors? All of these are well known. And of course, this is going back a long time now to look at these key visual acuity endpoints to show how much there was improvement versus our previous efforts to improve vision in both AMD and eventually diabetes, as well as vein occlusion. And so, although these have become adopted and have revolutionized to the tune of over 6 million injections per year, we do find that indeed ranibizumab did have some level of endophthalmitis and uveitis, inflammation inside the eye. And even from the very beginning, we understood that there was some small incidence of inflammation that we didn't understand. We didn't know if this was related to the technique or to the drug itself or to a host reaction, and perhaps we still are unclear whether that's the case. If we look at the other factors, deaths, non-fatal myocardial infarction, cerebral vascular accidents, non-ocular hemorrhage, and hypertension, we in fact find that there is equally this profile, and hypertension, I'll point out, was not insignificant. That hypertension for verteporfin, but also with ranibizumab, turned out to be elevated. And so that we don't particularly talk about that. And over these over 10 years of experience, it has not been felt to have a problem. We do feel that these medications do influence in some way the overall vasculature. Similarly, one of the findings in the diabetic retinopathy studies was the first example, and perhaps I think still the most important finding of these studies, is that there was a two-step improvement in the diabetic retinopathy severity score with anti-VEGF treatment. And we can see that in this example, how the eyes just look better. I'll remember the endpoints are only visual acuity, a very minute area in the central part of the vision. But something is happening to the entire vasculature of the eye, and of course to the retina. And this has implications for the upcoming talks when we talk about retinopathy of prematurity, where we add developmental factors and growth of normal blood vessels, homeostasis, and maintenance of vascular integrity. But something is happening here. Does the retina become healthier, or does it only look healthier? That's an area of investigation in my lab, and it's something that we hope to report in the future. So the CAT trial is really quite pivotal in so many ways, because of the first head-to-head comparison of ranibizumab and bevacizumab, one which would eventually be on-label and FDA approval, and the other remains off-label and not FDA approved. The takeaway from this slide is that there was no significant difference in the serious adverse effect and ocular adverse events from these groups, and both in a non-inferiority manner as well as the safety profile, it's felt that ranibizumab and bevacizumab were roughly equivalent. And if we looked at the ranibizumab groups, there's an extremely low, if we have combine the groups, only 3 out of 599, or approximately 0.5% of the ranibizumab groups had a combined endophthalmitis or inflammatory response, and none in the bevacizumab group. But as I put here in boxes, there was significant p-values for hypertension, systemic events. There was a systemic infection that was noted in the ranibizumab group, as noted here, with again a strong p-value. And there were gastrointestinal order and other organ class complications that were not easily explained. And there was a difference between the groups and between the medications. But again, looking at the study eyes only, endophthalmitis and pseudoendophthalmitis as a biomarker for inflammation was again noted from the beginning. And so ocular inflammation that can occur has a wide range of clinical presentation. Most of us experience very little inflammation at all. In fact, no inflammation, and some of it could possibly be related simply to the technique or to the lubricant in the syringes or any other host of factors. But serious inflammation can occur. Asymptomatic cellular reaction and with hypopyon, occlusive vasculitis, chorotic precipitates are rare because I believe that it's telling us it comes from a slightly different mechanism, which I'll talk about, and that you have to have a high suspicion of whether or not you possibly could have induced a systemic endogenous or exogenous in inflammation or infection. When you see this, you would certainly need to treat inflammation aggressively, but the question always is this a true infection requiring the pathway of culture and treatment, or whether or not antibiotics are needed? And certainly when the early treatment with the aflibercept, when we found this sterile inflammation, culture negative inflammation inside the eye, it was very unclear. When we see hypopyon, when we see aggressive cells, we're trained to think of endophthalmitis, and of course we should always think that. Even knowing the reports, I would say that I'm very cautious, and I always worry that this is the one where I indeed induce an infection. So as a practical point, remember to know that inflammation can exist. It should be treated aggressively, but to really assess whether or not there are factors such as fibrin, which might be more of a sign of exogenous infection. This all leads to recent events of brolucizumab, which was approved by the FDA as a single-chain antibody fragment with high solubility and presumably higher molar concentration than other VEGF compounds, anti-VEGF compounds. In the phase 3 Hawk and Harrier studies, brolucizumab was superior and had a greater drying effect on the retina versus aflibercept. And approximately 50% of patients could be maintained on an every 12-week brolucizumab dosage with non-inferior visual acuity outcomes compared to an every 8-week aflibercept regime. However, in the Merlin, Raptor, and Raven trials of neovascular AMD, BRVO, and CRVO, those 3 clinical trials have been halted. They've been black flagged and halted due to increased inflammation and vasculitis in patients who are receiving 4-week dosing. All 4-week dosing patients will be stopped after the initial loading dose. And it was found that there was a 4% intraocular inflammation in the Hawk and Harrier phase 3 trials versus a 1% in aflibercept, despite efficacy and non-inferiority of the visual outcomes. The Novartis internal safety review found a 4.6% of intraocular inflammation, but with 3.3% of vasculitis and 2.1% of vascular occlusion. Put another way, there's a 1 in 200 risk of a greater than 6-line visual loss due to occlusive vasculitis, and a 1 in 5 risk of a greater 6-line of visual loss if the patient presents with vasculitis. So if they have inflammation and they have occlusive vasculitis, the outcome is very poor. So because of this, and I would say that parenthetically that Novartis did a worldwide root cause analysis and actively participated both with the ASRS and the FDA to try to solve or better understand what is causing this. And that is one of the reasons why I thought today would be very important. Here's a report from the ASRS REST Committee, and they found that at 26 out of 25 patients had retinal vasculitis after treatment with brolucizumab, and the imaging studies were available. In most cases, 92% were associated with inflammation presenting at 25 days, but with a range of 3 days up to 2 months, 63 days after the most recent brolucizumab injection. In other words, it did not idiosyncratically occur after the first injection, but may have occurred later. The worst box on this slide is the following, that the mean visual acuity was approximately in the 20/52 range at presentation, but after the adverse event at presentation, visual acuity dropped to an average of 20/151, and at the final follow-up was a 20/243 with a range of 20/30 to light perception. Nearly half the eyes had a 3-line decrease in visual acuity at final follow-up, and 12 of those eyes, again almost 50%, had a final visual acuity of 2200 or worse. So the analysis of the imaging demonstrated that this vasculopathy was an arteritis, involved the retinal arteries in 91%, the retinal veins in 80%, and choroidal vessels in 50%, meaning that every layer of the blood vessels, both the retinal arteries, veins, as well as the choriocapillaris, was affected. And this has a lot of implications for what we think about what the mechanisms are for anti-VEGF treatment, even though they are, as a whole, quite rare. So as a safety overview, we're looking at both pegaptinib, bevacizumab, ranibizumab, and aflibercept. All the anti-VEGF clinical trials demonstrate remarkably similar SAE and ocular AE in the control and treatment arms. However, serious adverse events did occur in a less than 1% of intravitreal injections, including endophthalmitis and retinal detachment and traumatic cataracts, which again, it's quite rare. But other serious adverse events, particularly intraocular inflammation, increase in intraocular pressure, did occur up to 2%, and in the case of brolucizumab, up to 4 to 5%, which was quite high, and the cause for stopping that. So one of the questions is, why does this occur? So a lot of investigation has now centered upon the role of neutralizing antibodies. Neutralizing antibodies are naturally occurring. They exist in all of us, and they circulate in a way to identify pathogens. Viruses are one of them that can inhibit infectivity by binding to viruses. So these blue antibodies that are circulating might identify an antibody, a virus attached to all the receptors, and therefore they would be unable to bind to the host cell receptor and unable to enter the eye. In many cases, in turn, they are treated by monocytes or phagocytes and are removed from the body. Now, non-neutralizing antibodies can bind and inactivate immune cells as well, and non-neutralizing antibodies or ones that are insufficient can in fact be phagocytized partially, but then rupture those cells that it penetrates, and the resulting cytokines occur. This is particularly devastating in viral infections. We see that in dengue and Zika virus, and in some ways, we think about the cytokine and lymphokine storm that occurs in COVID infections as perhaps one of the ways that this occurs. So these neutralizing antibodies, although we think of the eye as being completely sealed from the outside world, we say that's immune privilege. It does in fact have neutralizing antibodies when sampling in the anterior chamber, and these do not necessarily are proportional to those found in the serum. So we do find in a therapeutic world, if we are treating with an AAV for gene therapy, then the role of neutralizing antibodies or the upregulation of neutralizing antibodies may have a role in the efficacy of whether or not you can transfect cells with the appropriate gene product. So it is a question. So now the other question is, do you have to, knowing that there are these complications, must you treat until the retina is dry, until all edema, all subretinal fluid is removed? And although baseline VEGF activity, in fact, the role of that may be unknown, it may be important for vascular health. And we're beginning to understand it somewhat more in mature cells, such as in the retina and the brain, but also in developing capillaries, such as in the during organogenesis and in the setting of retinopathy of prematurity. 4 studies at least, the CAT, IVAN, and HARBOR studies studying ranibizumab, and the ARIES study using aflibercept demonstrated that subretinal fluid may be protective against atrophy in age-related macular degeneration and were generally associated with better vision. But the correlation between OCT findings and vision remains unclear, and OCT has not been an accepted biomarker for visual outcome by the FDA because of the uncertain correlation between the two. Nonetheless, it does appear that if the vision is stable, the eye appears to be biologically and physiologically quiet, that perhaps we do not have to continue to treat with anti-VEGF compounds, at least in some subset of patients. So then the question is, for brolucizumab and other medications which have a higher risk profile, should all treatment stop? And the question there becomes one more, slightly more more philosophical. If we have a safety profile of an adverse event occurring only in 1%, and another drug where it's at 4 or 5%, then obviously the drug that is of lower complication rate would be preferred. On the other hand, we all have patients who do not respond, they're under-responder or do not respond at all to other anti-VEGF therapies, and for whom the benefit may outweigh the risk. And this is one of those areas where we are still, despite our growing dependence on data and our increased understanding of mechanisms through clinical trials, where there's still the art of medicine. So the important thing is to assess each patient individually and try to understand what the best needs of that patient are with the patient. Now, I want to come to the end by talking a little bit about the role of the ASRS REST committee, the Research and Safety in Therapeutics. The FDA has a very stringent, the United States FDA is very, very stringent in its need to have demonstrated clinical trials and reporting the complication rates, and in addition to having post-market surveillance. And but as shown with brolucizumab, it was approved and it had a good safety profile during the trial, but the collaboration and self-reporting of physicians from the ASRS and indeed around the world demonstrated that there was a important safety signal. And I was reminded of this in reading Dr. Goyal's superb compilation of patients who had developed mucormycosis in India during the current COVID crisis. Now, individually, we might feel that we were the only person, the only practice to see a patient with mucor. And it's through the collaboration of and the excellence of Indian ophthalmology that you have collaboration, you have discussions. But in fact, underreporting is a fact of life. And in fact, it's very difficult. No studies, in fact, are powered to look at complication rates. And so there's an opportunity, for instance, outside of our field of ophthalmology, to potentially collaborate and make a major contribution. For instance, do we know that for body weight or the dose of steroids used to treat COVID to presumably save the patient's life and prevent morbidity, is there a threshold above which mucor was much more highly likely to develop than not, even in patients with and without diabetes? That would be a very interesting and very, very important question. It could change the treatment for potentially millions of people. So the concept of us working together is extremely important. So anti-VEGF treatments have revolutionized the treatment of pathologic neovascularization and retinal vascular permeability. It's widely regarded as safe and effective, and adverse events can and do happen. Nonetheless, we're living in a golden age of treatment where our armamentarium is stronger and better than it has ever been. But clinical trials are not powered to ascertain the prevalence of rare complications. We would have to have studies in the hundreds of thousands, if not millions, to really demonstrate changes in complication rate. So the need for specialists to monitor and report and collaborate is in the best interest of society, our patients, and our profession. I thank you so much for the opportunity to share some of my thoughts this morning and to be part of this august organization. Thanks very much for your attention.
Thank you very much, Dr. Huang. That was a wonderful talk. And your idea of collaborating on COVID manifestations is well taken. I've started working on that as well. Thank you very much. And thanks for the compliments on my work. We wanted to know, you mentioned about the hypertension as a significant problem with these agents. So do all your patients get their blood pressure checked before the injection, in addition to the blood sugar?
I admit I don't. I admit that in our busy practices, I suspect in yours as well, that that taking blood pressure is not commonly done at all. In fact, if they report that they have very high blood pressure, I say, see your internist. Let's see how that goes. But although that was reported in the study, it may have, in fact, not have any clinical significance. It's something to I bring that up more as a point that we forget that the development of hypertension, if real, shows us that something is happening systemically as well as locally. And we should always remember that we may have other unintended effects.
Yes, so coming to that point then, in India, we generally wait for about 3 to 6 months following a major cardiovascular event before we can give an anti-VEGF injection. Do you practice that as well? What is the gap you would give or not give at all?
Why are you waiting 6 months?
I guess it's just an arbitrarily to reduce the complication rates, probably. We don't know.
No, I don't wait. I don't wait. I have been telling again and again, don't wait, because we are giving to ROP babies and they have so much of comorbidity, and the CAT trial showed there's no effect. So I don't wait. I've given to cardiac patients and stroke patients.
Yeah, I think it's important from a disclosure point of view to discuss that that the trials did not show a difference in the populations, and both premature babies have a high rate of complications, and elderly people have a high rate of complications, but with and without treatment. Nonetheless, I think it is in our best interest to disclose that this can occur, but the potential benefit is to save your sight. And for most people, even with knowing the information, they would proceed, even if they knew that they would. And that's the basis of informed consent.
So you wouldn't wait, even following a cardiovascular event, that would not be a criteria to wait for injection.
I think it would be a criteria to wait, but again, the question is about what is the cardiovascular event. In some ways, if you had coronary artery atherosclerosis and they presented to the cardiologist with 95% blockage in all 6 coronary arteries, it's very unlikely that the anti-VEGF actually precipitated the closure of those vessels. There's more likely fatty foods and chips. So that when that occurs, then you do have to disclose that, and you have a discussion with the patient. For most patients, most of my patients, if they are one-eyed and they have macular degeneration, and I think all of us frequently hear that, I'd rather be dead than to be blind. So we have to take both into considerations. And in the case of Dr. Sahara, if my child is blind, their life is terrible. Do what you can. We'll take the chance. We will go ahead. So I think we all have to wrestle with this, and that's what I say, the art of medicine.
So can we reduce the dosage in such patients where the risk is higher?
Change the dosage. I'm not sure. I think in many ways, changing the dosage is not likely to make a difference. We know that the eye is like Las Vegas. What goes in the eye stays in the eye. However, we do know that some goes outside. And so then the question is, are you really changing the risk by only giving a smaller dose? So you may have the worst of both worlds. You have less efficacy, but you still have side effects.
So the other question was, you see, we in India have been recent users of brolucimab, and now this warning a couple of, in fact, weeks back about 4 weekly dosing having been halted for brolucimab. So what is the current status of brolucimab in management of retinal diseases?
Yeah, I think it can be very topical around the world. For instance, in the United States, of course, we have a wide variety of options. We have compounded pharmacy prepared Avastin. We have Lucentis. We have Eylea. We have a number of different options. So in that setting, if those other medications are available, we tend to use those. And so brolucizumab is, I would say at this time, is ill-advised. People are not using that.
Yeah.
But think around the other way, if you had a lawyer ask you, when these other medications are available, why did you use this?
Yeah, that's what I was asking. Have you shifted back? Because there was the initial thrust of using brolucimab. I remember 2019 October, I've
never used it, but I know of no one who is using it in the United States now, unless they have failed all other anti-VEGF. So there may be a role in a small select patients, but even then, that's a very, very rare category. I did want to, there's one question in the chats that I wanted to address. And first of all, thank you all for the very nice comments. One of the questions is, why is Avastin not FDA approved? And it's actually quite a long topic, but to make it short, Avastin is a very, very difficult topic for the FDA because it did not undergo a clinical trial. It was not formulated for use inside the eye. It is off-label. And for them to give approval for something that did not undergo testing in the traditional manner would invite all kinds of other things. It would completely destroy the process that they have to safeguard the public. However, they know that many, many medicines are used off-label. So, so for instance, intraocular gas was never on label for the eye, or ibuprofen was only for osteoarthritis, but we take it for headache or sinus headache or other things. I did too much gardening. So those are all examples of off-label use. Now, what will be very interesting, and I have embargoed for this information, but I will be presenting the safety results by Out Therapeutics of a manufactured bevacizumab that after phase 3 trials, if it approves, would be a bevacizumab that would be FDA approved. If that's the case, that would solve all the issues regarding this as a non-FDA approved drug. So whoever asked that, it's very perceptive, but it's a slippery slope. Once you change the authorization process, very frequently you have lots of unintended consequences.
It's a question of money, I think. It's a question of money. There have been so many lawsuits against Novartis, and so many lawsuits. They have lost millions of dollars also in lawsuits. So you see, what is preventing FDA from doing a trial? You see, Avastin is available. It can be. CAT trial was also done. So I think it's a question of money that this trial is not being done. Otherwise, Avastin works wonderfully. All of us know that.
I completely agree, but the FDA does not run trials. They're the regulatory agency.
Yeah,
and Novartis does not want, if they do that, then they cannibalize their own drug, Lucentis. So they have no interest in doing that. And then it becomes a socioeconomic question. But I think our practice shows that, in fact, it is relatively safe to use. But we do find that poor compounding is an issue. And so they've changed the rules about who can distribute. You cannot buy Avastin and aliquot it in our own offices. Now it has to have strict guidelines. And so this new manufactured bevacizumab might solve that problem at a much cheaper price.
We'll take the last question from Dr. Subhadra Jalali now. Dr. Jalali.
Yeah, so thank you, sir, for the wonderful talk. I wanted to say that when I tried to publish the adverse events of bevacizumab in ROP, every journal rejected it, right from the Retina journal to American journal, British journal, and then the British journal sent it to the Archives of Disease of Childhood. And the question was that I reported vasculitis in those eyes, I reported liver dysfunction in some of those patients, and also reported choroidal ruptures. And but the community of the reviewers does not want to listen to some of these adverse events, especially for the liver test. It was like, oh my God, now we'll have to do liver function for the babies. So there must be some other explanation. You know, so that becomes a little difficult when you are, I'm sure you also have faced this when you're trying to publish adverse events. There's a whole lot of series of questions, but when you're trying to publish some good result, then it gets accepted more easily. So have you noticed choroidal abnormalities, choroidal ruptures? Because this is something we are quite concerned about. And also any hepatic toxicity, are there patients who have idiosyncratic hepatic liver enzyme abnormalities after anti-VEGFs?
Well, you bring up a very good point, and it is true that there is scientific bias in every field. People who feel that new methods, new ways of thinking may in fact be wrong. And yet, with complications, it's very difficult because they can be idiosyncratic. These are very, very sick babies. There's little or no controls. I have not seen a single case in 15 years of treating it as a primary physician treating ROP, both at the Bascom Palmer, at Johns Hopkins, at our institution. I have not seen any cases of choroidal rupture. I think that, again, there's so many, the technique, the dosage, the amount, the volume by itself, and then the susceptibility of these extremely fragile children, each of which are individual, making a conclusive statement difficult. The FDA does have a reporting site. It's not about publication, it's about reporting. And I think that one of the things I would suggest to all of us, if we have a complication that is associated, whether it is or not, we will not know until we have a body of work all over the world. And unfortunately, that's the best way we have to publish those. Small series, it's difficult to know. It's hard to draw worldwide conclusions from small series. So I appreciate you bringing that up and your vigilance on behalf of our most fragile patients.
So I think with this we can move on to our next speaker. We'd like to thank Dr. Huang for his time. He was very busy today. Thank you very much on behalf of the association, Dr. Huang. Thank you very much.
Very nice.
Thank you. Thank you.
We'd like to invite our next international speaker, Dr. Jay Chablani, to speak on his favorite topic, the new CSR classification.
Good evening, good morning, everyone. Can you guys see my slides?
Yes, yes.
First of all, thank you so much to HOA for giving me this opportunity to speak to all of you. And it's like coming home back. So many familiar faces. So as you all know that I have a special affection towards CSR, and I have been working on this for almost 5 years now. So today I'm just going to talk about a new classification which we reported last year, late last year, where we spoke about the multimodal imaging based CSR classification. These are my financial disclosure, and none of the disclosure have any relevance with this presentation. As we all know, CSR affects mostly young males, and we look for the exposure to steroids, type A personality, and mostly self-resolving. However, we all have seen that there could be an acute CSCR and chronic CSCR, and unfortunately, these terminologies and acute or chronic came up just on the basis of the duration of disease or symptoms reported by the patient, and we classically have been dividing acute CSCR if the patient has a duration of disease less than 3 months, or if it is more than 3 months, we call it as a chronic CSCR. When I was in LV Prasad in Hyderabad, we were working on this study where we were looking at discrepancies in current CSCR classification, and this paper came out in early 2018, where we actually looked at 100 eyes of 100 patients. We included 10 graders around the world, and you will be surprised to see that out of these 10 experts, we realized that they used 36 different terms for the same CSR patients, and the poor agreement was noted between the graders to the lowest of fleece cup of 0.134. So this paper definitely showed that we really need to work on something more stronger classification. And these are the different terminologies, and you can see, and you'll be surprised to see that how we all have been talking about different ways about CSCR. Some people call it as chronic, recurrent, acute on chronic, chronic multifocal, all different types of calling the same patient. And this is what we showed in this paper. So we realized that what was missing in the conventional classification for CSCR is that there was no clear definition. The extrafoveal leaks with no ocular symptoms, we really don't know how to classify them. We really do not know to differentiate between a non-resolving CSCR or a chronic CSCR. We really don't know how to talk about CNV associated with CSCR or bullous exudative retinal detachment. And unfortunately, till now, we do not have anything which considers multimodal imaging, which is now the backbone of our retina clinics, and bringing this information into the CSR classification. So there was certainly a need for new classification for CSCR, and this work I started back in 2016, and we included multiple experts in CSCR around the world, and you can see that the distribution of these experts is for almost all parts of the world. And we sat together and discussed about a CSCR classification, and this is something which we published last year as in ophthalmology retina, where we reported as multimodal imaging based CSCR classification. And this is what I'm going to take you to today. So before we really jump onto the classification for CSCR, we wanted to establish diagnostic criteria for CSCR, because as you might have seen one of my paper in survey where we showed that how CSCR could be masquerading with so many diseases. So we really needed to come up with a diagnostic criteria, and we reported a major criteria if the patient had both of these criteria. The first was presence or evidence of prior SRF documented on OCT. And we did rule out most common masquerades such as uveal effusion syndrome, dome-shaped maculopathy, inherited retinal diseases, and so on. The second important must-have criteria was to have at least one area of RP alteration on fundus autofluorescence, OCT, on infrared. So just to bring your attention to the word called RP alteration, we are not talking about RP atrophy. So we really wanted to understand if there is any change in RPE, and we do understand that it is not possible to have every clinic to have an autofluorescence. That's why we gave a wider range of imaging modalities, including fundus autofluorescence, OCT, or infrared. And the minor criteria were that if the patient had to have one of these criteria, one was the mid-phase hyperfluorescent placoid areas on ICGA. We understand that not everybody gets an ICGA, particularly in the West. In the US, people don't get ICGA, but you need to have at least one area of one or more focal leaks on fluorescein angiography, or a subfoveal choroidal thickness, which is more than 400. I do understand the variability associated with age and axial length and the ethnicity itself. So we need to have one of the minor criteria and both major criteria. So once you have made the diagnosis of CSCR, let's move on to how do we actually classify CSCR. So we wanted to classify on a basis of RP alteration. So we classified into simple and complex. If your simple is when the RP alteration is equal to or less than 2 disc areas on any of the modalities which I just described, it should be either, and complex is if it is more than 2 disc areas. And atypical was when you had a bullous variant, when you had a CSCR secondary to RP tear associated with any retinal diseases. So simple or complex could be divided into primary if you're seeing your patient for the first known episode, or if a recurrent, if the patient definitely shows signs of previous episodes or resolved episode, or if the patient had resolved CSCR when there was signs of previous episodes, but there was no presence of SRF. And if the CSCR is, the subretinal fluid is persistent for more than 6 months, we call it as persistent. And we go into the further details on OCT, including outer retinal atrophy, such as ONL thinning or EZ damage. And then you lastly talk about the presence or absence of CNV. And if the fovea is involved, we wanted to give it a plus sign. So on the basis of this, we ended up making an algorithm. How do you actually classify your CSCR? Because before we really start coming up with the treatment guidelines, we wanted to come up with an algorithm to classify CSCR. And I'll take you through this algorithm. Whenever you suspect a CSCR, the first thought is that whether it is a typical or an atypical. Once you have diagnosed your patient as a typical CSCR, let's now focus on the RP alteration on autofluorescence or infrared or on OCT. If your RP alteration is less than 2 disc areas, then it is a simple CSCR, and the rest of the steps which we went through in the last slide, you talk about the subretinal fluid, outer retinal atrophy, or CNV. If your CSR, if the RP alteration is more than 2 disc areas, then it becomes a complex CSCR. Then you go through the next steps of subretinal fluid, outer retinal atrophy, and intraretinal fluid. and CNV absence or present. I'm not going into the details because obviously you have seen that the overall approach is to understand and approach your patient while classifying the CSCR not just on the basis of duration, but actually using some objective criteria which are present right in your clinic using the images. So the strength of this classification is that it is a first objective classification for CSCR, which is multimodal imaging based. This classification is being validated by our group, and the other groups have also reported almost the accuracy of 0.87 to 0.92. It is a reproducible classification. It does correlate with the visual acuity. Some of my papers are under review where we are showing that this classification correlates with visual acuity based on these critical OCT features, mainly on outer retina. However, we understand that there are current challenges which, because your patients can have varied presentation, we understand that CSR presents in every clinic in a very different manner. Though OCT angio is becoming common, but on purpose, we did not include this OCT angio because we still have to have a much better technology and much more widely available in every clinic. You guys must have noticed that we did not talk about the pachychoroid word because we all understand that this word still is not very clear, and though it is being used very commonly in the clinics, but we still do not have a very clear classification for pachychoroid. And I'm sure that you must have seen a recent talk about the venous congestive theory for these diseases. We are yet to work on this, and we hope to incorporate this in evolving classification. We did not speak about the fellow eye because we still don't have a certainty that a CSR is a patient disease or an eye disease. We could not really include systemic medications because we all know that this also plays a very important role, but that needs further understanding about these drugs. So with this, I would like to conclude that this is the first multimodal imaging-based classification for CSR, which is validated and appears to be reproducible. Then the next step is to bring this classification into the clinics and see that how we can make it further better. And eventually, the next steps are to establish treatment guidelines for this complex disease. With this, I would request all of you to have a look at this paper on ophthalmology retina, and looking forward for the more inputs. And with this, I would like to thank LV Prasad and University of Pittsburgh, and thank you all for your attention. Thank you so much for giving me the opportunity.
It's an excellent paper, Dr. Chablani. Anybody has direct questions to Dr. Chablani? Okay, I would like to ask you, I have seen a few patients who have a lot of exudation, subretinal, almost like what you might see in a diabetic. But these are very dense at the posterior pole with some serous detachment. And there is a gravitational track of these exudates going to the inferior periphery, and again forming a lot of exudates at the periphery. So are these CSR, and do they fit into your classification anywhere? Because they do respond to PDT and not to anti-VEGF. You can give as many injections as you would like, but they don't respond until you do PDT.
Excellent question. And I think we all have struggled a lot with such patients, and we understand that CSR could be very exudative. It could be ranging from a small bleb, which is full with exudates, to coming with an exudative detachment and a subretinal fibrosis even. And if you are seeing an RP track, which definitely makes it a much larger area of RP alteration. So in my opinion, to our newer classification, it will fall into a complex criteria. And as you certainly described that these are complex cases, so definitely it falls into a complex class. Thank you.
Dr. Jay, what about this obstructive sleep apnea association with CSCR? Do you really investigate in your practice?
I know that there was a recent paper from Stanford where they showed that the OSA is associated with CSCR. And I have one patient here who has obstructive sleep apnea, but I believe that I'm sure that you all are aware that OSA could be associated with so many diseases ranging from venous occlusion to whatnot. So we really don't know. And in the same way, in complementary, I would say CSR could be associated with so many diseases. So I really don't know that there is a very clear-cut association or not, but I do talk about this to my patients since I saw that paper.
Jay, just one issue. I think we've discussed this also before, that this was also my opinion, that the sort of so-called acute CSCR usually doesn't progress to so-called chronic CSCR. So these are, to my mind, these are two very different entities, the simple one and the complex one. So I think the next step is now to try to find out what are the pathogenic mechanisms. That I think the pathogenic mechanisms are different in the simple ones and the complex.
Yeah, ma'am, I have not left your question. It has been there since for last 7-8 years in my mind. So to tell you something, that now I'm almost done with my next manuscript on the long-term outcome, where we are looking at the 10-year follow-up of our CSR patients. Because I truly believe that acute does not lead to chronic. That means simple does not suddenly become a complex. But at the same time, to give you, I'm sure, I don't remember the exact numbers, but our theory still holds true that the acute does not become chronic over the 10 years. There are very few number of patients which have actually started as an acute and became chronic. So you will see very soon in some of our publications. Thank you.
Excellent.
Jay, somehow you need to include the pachychoroidal thickness, which I read your manuscript, this thing, publication also. So that was one thing which was missing, but you have nicely pointed out in your presentation. That's good, but somehow you need to include that.
So sir, the challenge with pachychoroid is that we really don't know what is the normal range of choroidal vessel thickness and whether this is an acquired disease or a congenital disease. So now you should see one of our recent paper which came in Progress Retina and Eye Research, where we have spoken about a new theory called chronic venous congestive choroidopathy, which actually talks about the connection of seeing a pachyvessels, so-called pachyvessels at the posterior pole, and its relationship with the vortex drainage. So eventually this all is going to fall into one class of CVC, chronic venous congestive choroidopathy, which will answer many of these questions. So we still cannot really pinpoint a number for the choroidal thickness, but rather an overall structural change, which is probably becoming an acquired disease over the time. But
and probably another aspect for your classification is it is not a prognosticating classification.
Yes. So I would say we have just taken a first baby step of talking about the disease. We have far long distance to travel. Yeah.
Okay, I think move on in the interest of time. Dr. Jay, you were saying something?
No, I mean, if there are no questions, we can move on.
So now a really interesting talk by Dr. Subhadra Jalali on threat to life of vulnerable patients in the operation theater, case-based experience at LV Prasad. Dr. Jalali.
Hi, everyone. So thank you for being here to listen to this talk. I'm sure that, when we have seen this yesterday, how Simon Cager, the heroic captain, gave CPR, and many of you would have seen this on the field. I think it becomes very important for us to know that, whenever somebody falls down, there's an event in your OT, you need to give CPR. But my talk is not going to talk about that part of management. The management that I'm going to talk about is the public relations and what all you need to do to handle that situation when you have this acute death or likely death in the OT, and what you need to do. And then I will go very briefly on the team preparation and how to analyze the event, because that would need a longer talk. So the immediate steps, I think, are, of course, that it's a very stressful situation. Suddenly you notice that the patient is not breathing, or he's fallen down, or suddenly the pulse oximeter is showing bad report. Then it's a very stressful situation. People are running around. There's a code blue announced. So that part is taken care. But I think in that situation, there are 5 very important steps that you as the leader or your team has to do. The first thing is sincerity. Sincerity, do not make up things. Whatever the patients and the families have queries, answer them very sincerely. Transparency, let the loved ones see and understand what is happening. Don't hide it behind closed doors. Don't get nervous. Something is happening. You need to be transparent and let the people know what you're doing. There needs to be a lot of empathy at that point of time. This is not the time to, settle scores, to say that, because you gave insulin to your father and didn't give him food, that's why he got hypoglycemia and he died. And then they will say that, like, you didn't tell us to give food. So this is not the time for tutu meme. This is not the time to settle scores. You need to show the empathy and care for the family and their emotions, because they are going to lose, or they've already lost a loved one. The purpose is very important. At that point of time, when you're in that stress, you need to know that you are doing something which you are believing is the correct thing to do, because that is something you have to have full confidence and purpose that I'm doing something and this is in the best interest of the patient, and I need to go forward and do this thing at this point of time when the patient is dying or almost dying. The thing is that in an eye hospital and in an ophthalmic setup, we very rarely face such situations, thankfully, but then that makes us unprepared for such a situation. And the last one, but not to be forgotten, is the security of everyone. We know that especially in our country, it may not be related to many other countries, that the security of everyone, your staff, your patients, your hospital is very important. In Singapore National Eye Institute, when we visited there, we saw a big board in all the floors which said that don't mishandle our staff. You will be handed over to police if you try to assault our staff. So yeah, it can be very dangerous. So these steps, I think we have to keep in mind and be prepared for them whenever the situation occurs. So of course, the medical treatment is priority. The code blue team will come in, they will do the CPR. Then to manage the situation, one person should take charge. There should not be many people who are taking charge. Usually it will be the surgeon, but if it's a junior surgeon, then a team lead will gently remove all those who are not needed. So those who saw the CPR on the football field yesterday, they noticed how the players immediately cordoned off that area because there was no police there to cordon it off. But the players themselves immediately cordoned off the CPR event. So, remove all the onlookers, cordon off the area, calm down everyone so that the focus is on the patient and saving life of that patient. Wait for some time for the situation to stabilize, for things to settle down. Then get in a relative of the patient to see when the resuscitation is happening. And I'll elaborate on this little more because I've been questioned on this multiple times. The most important thing is that only one person should brief the family with a single version. And again, these are two things that I'm going to elaborate a little more in the next part of the talk. Make sure that the attendant is seated comfortably while the people in the theater or in that situation are running around trying to get this, that. The attendant should have a stool or a chair so that they're seated comfortably and not getting nervous, because they may again collapse or have a vasovagal. And facilitate them to communicate with the family outside. Obviously, you're not allowing the whole family to come in, but allow them to have a phone call or whatever they want to do so that they are in communication with their own family. Organize the security and be ready with your grief counseling team. So the question was asked, like, what is the best time to call the relative inside when the resuscitation is happening? I think the most important thing is that call the relative when you're sure that things are settled and there's a dignity to that patient. You're trying to resuscitate, he may be naked, you may have undone his clothes, the patient may be lying on the floor, the bed sheet may not be good. So make sure that there's some dignity to that patient and things are a little settled, and call in the attendant, but definitely call the attendant in before you declare death. They must see the resuscitation process. They must be there to see that you did all your best for the patient. Now, whom to call? So this is very important, that whom should we call inside? So sometimes there's only one person, so obviously you call them. But if you have already had a interaction with the family, then you would know who is the most responsible person. It's not necessary that the husband is the most responsible person or the man of the family. Sometimes they may be aggressive. So you may know that the mother is more strong, and it's better to call in the mother and the more mature person. So the pre-op interactions would decide, and you would know that who is the responsible person who will take it in their stride and come in. So that is the person you should call inside. And where to tell? I think it's very important before they enter and see the chaotic scene or the active field of resuscitation in the private space. They must be briefed about what happened, what is it, and what for them to expect when they enter the active field, and what to tell. This is, I think, again, very, very important. In that moment of confusion, worry, nervousness, negative words should not be used. Otherwise, also in counseling, it is taught that don't use negative words. So what are negative words? Negative words are like, your patient is doing bad, your patient has a risk of dying, the surgery has failed, or there's going to be a damage to the tissues, or there's going to be death. Don't use these words. Use positive words. Say the patient is not doing as good as we want, or say that there's a risk to life. Patient has collapsed and there's a risk to life, or say that things are not going up to expectation. So it's like calling the glass half full rather than calling the glass half empty. And this needs to be practiced. This needs to be practiced in your day-to-day counseling and the way you address things. Rather than saying damage, say it's not as good as. And there's much more information available on the net of what are the positive words you can use in negative situations. Then, as I said, that only one person should brief with a single version. Now, this is very important. And what is the best time to give this version? You need to give a summary or a brief précis and some details of what is happening. I think when the things are a little settled down, people have done the CPR, they've intubated the patient, or whatever, they put the IV line, things are a little better. Then before calling the attendant preferably, or even if the attendant has been called and the team is taking care and the attendant is there, you need to move out. You as the team leader need to move out and go to a quiet place and get the people to record what happened. And you need to get this information from the medical record. If you have access to CCTV, get the CCTV. There may have been observers around who observed something happening. So write down every step with timelines. Ensure that there's no discrepancy. This is very, very important. If you give one version and after 5 minutes somebody else gives one version, or you change your version, I will give example of that, then it creates confusion in the mind of the patient, attendants, and then they start doubting your sincerity. So it's very important to write down every step of what happened, 1, 2, 3, 4, and then that is the version which should be conveyed to the family. So I'll just give examples. So here this was the first death I faced. This was a stage 5 ROP baby. Baby was 7 months old. And once we gave the anesthesia, the baby did not, come out of anesthesia. It developed severe respiratory distress and did not resuscitate, and the baby died. This patient I had operated the other eye 4 months ago and had been okay. And then baby had been sick for 2-3 months. And so we could not do the second eye at that time. And, we did exactly what I explained to you. We did. And there was no MLC filed by the father. And I was very surprised that the father was consoling the mother once we declared death, that, it's not the, fault of the doctor, it's not the fault of the hospital. Our child was sick. Our child had frequent illnesses. And, we have had very great interaction with the doctor and with the staff. And so we have to take it in our stride that our child has passed away on the operation table. So this whole thing was effect of a very comfortable, positive interaction with the staff at multiple visits when the patient has visited our center. And, so it was a very, very sad moment. It was a very moment full of empathy. We had this baby with us for 4, 5, 6 months, and then we lost this baby on the table. But the whole atmosphere was such that the father himself was, conveying to the mother that, we have to accept this death. So this happened when I faced the first ROP surgery death in my OT. Now the second one, so of course then we do an analysis whenever we have a death like this. So we had a detailed analysis. This was very early in our time when we were not that adept at handling a lot of these babies. So what we came to understand after getting an external audit of our case, and all the experts sat and did the audit, we found that the preterm babies, they can develop paralytic ileus, that is an abdominal distension. And so we have changed the protocol. Now all babies who are less than 2 years have to have a nasogastric tube placed during the anesthesia. And this is removed only when we are sure that the baby has well-established breathing, and we can reinsert the tube if abdominal distension is noted. And we do get this type of conditions once in a while. So now we've learned that lesson. The other thing we learned was that the preterm babies take a lot of time to metabolize the anesthetic drugs. So the prolonged recovery is very normal. So, normally the anesthetist note that the effect of the drug goes away in 30-40 minutes. But in these babies, it takes 1 hour, 30 minutes or 1 hour, 40 minutes for it to go away. And so initially they used to, extubate, and then the baby would go into apnea. So now we have made that rule that, don't extubate, wait. And the baby, they just take some time and then they're fine. So, and of course, we already have SOPs like minimal drugs, no cocktails. In all high-risk cases, we have 2 anesthetists and then neonatologists around. So those things are already in place, but these are the things we learned from this particular case, and so the protocols were changed. So now we have this another patient who was a diabetic. So this was an adult diabetic. He had an uneventful surgery in the evening. The fellow was operating. He was about 67 years of age, diabetic, well controlled. And then he walked out of the table along with the surgeon. And then the surgeon went to write the discharge summary, and the patient said, I want to go to the toilet. The toilet is within the theatre complex. After coming out of the toilet, the patient complained of dizziness. Immediately, the nursing student who was there put him into the wheelchair and onto the bed in the pre-op area. And while they were putting on the bed, they suddenly noticed cardiac arrest. Code blue was raised, CPR was started, the anesthetist was there, and the nurse was there, so they started everything. And what we noticed was that all the OT staff just collected around the bed. These were all irrelevant onlookers. So the attendant was called in. His attendant was about 26-year-old, and he watched that the patient was not responding. I was just walking past that place. It was not my patient. I was just walking, and what I noticed was that loose talk had started. So some of the staff was telling the son, your father is a heart patient, that's why he got this problem. Somebody else told him, actually he vomited and the food went into his lungs and that's why he is bad. Another one was telling him, maybe he's got sugar dropped. So the surgeon, who was a young fellow, I could see was feeling very nervous, was wobbly, was sweating. So in a few seconds, the situation would have got out of hand. The son said, my father has no heart problem. He underwent pre-op evaluation. So why are you telling me now that he has heart problem? You only told me to feed him. He's a local anesthesia case. Now you're telling his food has gone into his lungs and his sugar was okay. I just had lunch with him at 1 o'clock. And now at 7, you're telling me he's not going to be anymore. So, so there was a lot of back and forth, this thing. So the most important thing was, as I said, removed all these onlookers and everybody go out, put the hand on the son's shoulder, asked him to sit down, asked him to make telephone calls to his relatives whom he wants to call. The gag order put on all team members. Nobody's going to speak anything. Just take care of the patient and move the, the nervous surgeon out to a quieter place, calm them down. The patient and the theatre assistants took care of the patient. And then the hospital security was called in, and they called in the local police person to be around in the OT. And the OT admin was briefed on preparing an ante-room for the family discussion, because we expected a lot of family members and angry people to come in very quickly. So then we just did what I said. We took out the medical record, looked at the patient's details, and everything was written down. Every event and timeline was noted, and a still final version was noted on all these things which I said happened. Anything which was vague, this is very important, anything which was vague or non-essential was left out. It was not put there, like, patient had some cardiac evaluation done. So this was not the time to, fight out and say that he has heart disease or he doesn't have heart disease. So anything vague was left out from what we were going to talk to the family. So the cause of problem was discussed amongst ourselves, and it was concluded that this was a natural cardiac arrest the patient had. It was not related to any drug or any procedure that the patient had. And of course, after some time, we declared the patient dead around 8 o'clock on that night. Now the whole family had collected. I think there were almost a dozen men and women there in the room by that time. The whole family has come. Obviously, they were in very threatening and angry situation. So we just sat down there with myself, the anesthetist, the surgeon on one side of the room. They were sitting on the other side. The hospital security and the policeman were sitting within them. So the one written version that we had written, we just read it out. We explained to them. We expressed, genuine empathy for loss of our patient. And this is what we have explained, that this was a regular cardiac arrest, and it was good, or a lot of it was happened in the OT. So everything that was possible was done. It could have happened when he was walking home, or it could have happened in his home where the CPR would not be available. And now the policeman was very important. He was neutral. He said that I am ready to lodge a complaint. If you want, I will secure the body and shift it for post-mortem if the family wants to file a case against the hospital. And he said that, like, it seems that there's nothing wrong in the case. Patient has walked in and walked out and has not been given any systemic drugs. It was an ambulatory eye surgery. So we also emphasized that, you know, all the tests were done, everything, all the precautions were done, the surgery went off well, and this was supported by the son. The family wanted to see the CCTV, that this is what happened, what the version that we said. So then we said, yes, we will give you the CCTV footage. The family was left alone for 10 minutes to discuss the options. We moved out. And then after 10 minutes, when we came back, the family decided not to pursue the matter. I think they had cultural sensitivities about the post-mortem, and possibly they believed the chronology of events, which was also seen by the son when he was in the OT and saw us resuscitating the patient. So I think what helped us was that, you know, we were accredited. I think if this had happened 10 years back, we would not have known what to do. We did not have systems in place. Most of the eye hospitals may not have these systems in place, but I think it's very critical to put these systems in place. You know, the code blue protocols, what we do, the trained staff, everybody has been trained in basic life support, advanced life support, the CPR team, regular mock drills. There's a very good relation we have with the local police team. I send them thank you cards and flowers off and on, you know, whenever they help us in the traffic or whatever. So there's a very good relation with the local police team. We have our security people have good relations with them. So they could come immediately in the middle of the night. And the physician and anesthetist supports were there. But most important was the robust digital records, processes. You know, everything is time controlled. So we can just write 7:30 this happened, 7:35 this happened. There has been some CCTV monitoring, which we showed to them. Most important is grief counseling. So have teams, we do these mock drills of grief counseling and proper dignified send off, how the patient is going to be wrapped, how the patient is going to be sent off once they die. And then there's a leadership training, how to handle critical situations. So these trainings to the senior staff and to everybody, you know, has to be an ongoing process in the hospital to give that training. And then there has to be a professional purposefulness. When all this was happening, you know, I was very calm, and somehow it seemed to me that, you know, there's been some spiritual thing. I'm there by chance, and, you know, everything will fall in place. And there was no nervousness, or there was no worry or anxiety that, you know, we'll be assaulted or some case will be filed. And we were okay. You know, it will happen. The purpose was to give a dignified send off and give empathy to the family, and, you know, take care of your staff and your surgeon and everybody around you. So the root cause analysis, of course, as I said, I'm not going to go into a lot of details about root cause analysis. So I've handled almost 8 or 9 deaths so far, and things have been, you know, learning. Every episode you learn, you take stock of the situation, and you learn how to handle these things. So I want to conclude by saying that the retina surgeries, whether it is ROP or, you know, diabetic patients, extremes of age, we are handling patients with multiple comorbidities. Many of us are not in multi-specialty hospitals. We may be in small hospitals. So the root cause analysis has to be very ruthless. You should have very detailed, honest, external internal experts on scientific fundamentals. The protocols should be changed. And in most of the cases which we found, we had very close and single communication and empathy with family, besides the security protocols. And I think so far, you know, we were able to handle these situations. Thank you. I think we have to build our teams. You are giving sight to patients, but you have to be aware that you can be in very critical situations, and you should be ready to handle them.
Excellent talk, Dr. Jalali. Excellent talk. Anybody wants to make any comments?
The only comment I wanted to make was these talks are not easy to give.
Yeah.
It's so very difficult to handle such situations. And hats off to Subhadra. Only thing is that surgeon has to show patience and listen to the family. Always give ears. So if you don't, then they start smelling fishy.
Yeah, as I said, that the tutu mama can go on in court as and when it is required. At that point of time, just, you know, calm down and don't get into an argument.
Yeah.
Just don't get into an argument. Just settle the situation. Don't try to justify yourself for them.
Yeah.
Just handle the situation.
I think even in a multi-speciality hospital where I work, it's a very difficult to manage a unexpected death actually. And one of the causes, which of course we don't have it often, I've only seen one case, but I think one of the reasons can be where the anesthetists get very complacent and they leave the junior most person. And that happens often, leaving the junior most person, and the anesthetists just go away after inducing the case or starting the case. And I think the junior doctor is simply not equipped to deal with some situations. And I guess that has to be, I think we as surgeons have to put our foot down and say that each of our patient deserves an experienced, good anesthetist, even if the patient looks stable and looks low risk, because we never know what happens.
Yeah, I think this is very important. So we also have to learn as surgeons the pulse oximeter, in your ears, that tin, tin, tin comes, and the moment you see something, you say like, call the anesthetist. Where is he? So you also need to be very vigilant, alert to the, the monitors which are going around, and not only because your laser does tin, 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 and then your monitor is also doing tin, 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 tin. So you need to keep your ears on that monitor. That's very, very important. When you hook the muscle, immediately you should notice that there's a bradycardia. So that alertness has to be in you also. Everybody has to be alert.
We don't need to be on the best of terms with the anesthetist, because our repeated demands for safety does lead to some kind of friction with the anesthetist. But I don't think it's important. It's better that we let them know that our patient deserves the best, and we don't want to compromise at all. So they better be there. The senior surgeons, the senior anesthetists have to be present.
So one of the things that I always do is that I'm always with the anesthetist. That I learned that, a dialogue, because see, they are always in the shadows. So we get all the good things from the patient, you did good surgery, but when something happens, then I've noticed that the surgeons leave everything to the anesthetist to explain. So as I said in my talk, it's always a team. So me and the anesthetist, we both sign the high risk consent, both for surgery, both for anesthesia. I'm with them, they are with me. And so, we have to be like a full team. And I didn't talk about it, but even the parents, I always try to be in the team before I start even, taking care of the baby. So when I do the pre-op counseling, because these are all very high risk cases, 1 kg baby, 1.2 kg baby, they come and within 8-10 hours, we put them in the theater. So putting that family there and telling them that you are part of the team, I am taking a risk for your baby. And so you better take the risk for your baby. And together we are going to take the risk. Don't ask me to take the risk. I am not asking you to take the risk. Together we are going. So put them in your team, the family members in your team right from day one.
Yeah, true. That's very good.
So maybe for Dr. Huang, some of the things may be more relevant to our country. They may be a little different in other countries, but I think that empathy and security and drills and protocols, I think would be similar every place. Yeah. Mahesh, you wanted to say something?
No, not really, Dr. Subhadra. It was a great talk. I heard this for the second time. But then, of course, empathy and whatever you said, and I perfectly agree with you.
The first time I heard this was from Professor Badrinath when he came to give the first guest lecture at LV Prasad Institute. His talk was on 5 deaths at Shankanetralaya, and that was the first time I learned, and I learned a lot from his talk of how to handle things and how he managed them.
Okay, as a parting shot, what I would like to say is that as ophthalmologists, we try to brush problems under the carpet before surgery. Oh, the anesthetist has asked for this evaluation and that one, and now the patient has to go to the cardiologist. So we try to do that, and then ultimately we might end up regretting those kind of hasty decisions. It's better to evaluate, and hold on. If the anesthetist is not comfortable, don't push them emotionally into the surgery. Just hold on, tell the patient there is a risk, let the patient accept the risk. Mostly they will not accept it. The family will say, let the eye go, don't take the risk. So let us not take the risk on behalf of the patient. Many times we underestimate the problem, we don't understand.
I agree with both Mallika as well as Subhadra. You see, in a multi-specialty, it may be easy, but for a corporate practice or solo, what I firmly believe after so many years is that cataract surgery is totally different. They never believe, because cataract surgeons are the people who hire the VR surgeons. So all VR surgeries, irrespective of a simple vitrectomy or a complex, should have a pre-anesthesia checkup 100% done. It's not that anesthetist sees the patient on the day of surgery, so he will not be familiar with the case.
Yeah, especially retinal cases are very complicated already from diabetes, hypertension, because the fact that retina is involved is already a window to the systemic status. So my anesthetist always say that your cases are so complex, very complex. In fact, we don't see such complex cases even in the other specialties.
So that's the reason, Malika, I wrote there, only the stress of VR surgeons can be understood by a fellow VR surgeon only. So that is the...
Absolutely. Not even the assisting staff understands our stress.
Yeah.
So there is a scuffle even between the surgeon and the assisting staff.
Yeah, I don't want to, have people go out with the impression that we should not take high-risk cases. That is not the purpose of the talk. When we have high-risk cases, as I said, we need to counsel the family, get them together, get all the tests done, keep on building your team, keep on building systems. So when I started, 1 kg baby to 1 point, even 2 kg baby, my anesthetist refused to anesthetize. They would say 2.5 kg. I would tell them that, 900-gram baby in a neonatal hospital is undergoing tracheoesophageal fistula surgery on day 1 of life. So don't tell me that I cannot operate a baby who's 1 kg. You tell me what you need. You need a neonatologist, you need a neonatal ventilator, you need a neonatal ICU. What do you need? You tell me, we will organize. So slowly, over a period of time, we have got PALS training to all our nurses. We've set up NICU in our hospital. We're the first one to do it. RP Center did it next. So what I'm trying to say is that we should build up the systems and the teams and the infrastructure, and slowly then we can take up these cases. But the whole system has to be set up, and everybody has to learn the CPR, learn the systems. Then we can handle very tough cases. People are handling so tough cases all over. So we can also handle. I'm ready to do intrauterine surgery. People are doing intrauterine cardiac surgery. Why? I have to do intrauterine retina surgery, intrauterine laser for FPVR. We can do it, but the thing is, we have to build the teams and the expertise for those things.
Only difference here is that you are willing to do, but you see, never the VR surgeon should, in a high risk patient, I'm talking, all these diabetics and re surgeries, don't be so enthusiastic to do it in the first shot. No. Let patient have a review somewhere else also, yes, because they will roam around and have discussions everywhere. Then if you do, he is more obliged. But if in the first instance you are very hyperactive or maybe hyper enthusiastic to do that case, then things can become slightly tricky.
Systems are important.
Yeah.
If you have systems, then there's no question of hyper or hypo.
Great talk.
Excellent. So with this, I think we can conclude the meeting, and I'm on behalf of HOA, I'm extremely grateful to our guest speakers, Dr. Huang, Dr. Chablani, Dr. Lalit Verma, Dr. Mahesh Shanmugam, and our host speakers, Dr. Jalali and Dr. Mudit Tyagi, and the panelists who have been patiently applying their minds and putting in thoughtful comments, and even those who are silently supporting in the background, the panelists. So, and the audience for their attendance, the Sun Pharma for their support, and the technical team. So I would like to thank everyone. Dr. Babu, have I left out anything?
No, I think you covered everything, no problem.
Thanks a lot.
I think all talks went on well, and we have never curtailed the duration of talks. Initially, we were hesitant that the time, probably the duration is little longer. We miscalculated the duration. So everything went on well. I think it's better to say adieu and relax for this night.
Okay. Bye. Thank you.
Thank you everyone. Bye-bye.
Thank you.
Bye.
Thank you, Malika. That was very nice.
Thank you very much. Thank you, Dr. Shanmugam.
Bye, sir. Bye, everyone.
Okay.
Bye,
Malika, bye.
Thank you.
Bye.
Bye. Thank you. Good night.